So, my dear doctors, welcome everyone to our past paper course. But before going through the session, let me tell you the wisdom behind starting with the past papers. We know that past medicine is the gateway for MRCP Part 1 preparation. But you might be wondering why I choose the past paper instead of past medicine or past test. Number one reason is the RCP sample question pattern. This RCP sample question pattern defeats perfectly matches with the main RCP exam question pattern. But we have only 197 sample question, and it's impossible for me to give you the real flavor of the exam question pattern with just only 197 question. So I need to choose an alternative one, and the past papers. The past paper fits perfectly there, and also the past paper was the gold standard for the recent January diet exam. And all of you know that the past medicine question pattern, they are really pretty straightforward, and they just give you the core foundation of knowledge. Past medicine provides you with the basic knowledge, and you can apply those knowledge when solving either the past test question bank or the past paper, and also the BMG or the on examination question bank. And the MRCP question or the MRCP question pattern is all about application of your knowledge, with the exception of a few question. Applied knowledge can only be practiced using the past papers. And those tricks and tips which I always share with you, these tricks and tips can best be evaluated using the past paper. They can be much more evaluated by solving the question from the past medicine. And I can only teach the exclusion theory with some advanced pattern of question, and the past paper questions are relatively tougher compared to the past medicine, and they are also advanced pattern of question. And when the exam will come near, let's say just 2 weeks or 3 weeks, 3 weeks away, I will also launch another course giving you an idea about all important PowerPoints and also the one-liners from the past medicine and also the past test, and they will be crucial for your preparation just before the exam. And let me tell you one thing: our session should be interactive. You will be the one who will be reading the question, and you will try to answer them. And I want all of you to respond and don't hesitate to make mistakes. I will of course congratulate you if you make more and more mistakes, because if you make mistakes now, you would be safe from making further errors. And I always fear that if you don't respond out of shyness or hesitation in our interactive session, you might make more errors in the exam. So always try to respond much in our interactive session. And I think I have given you just an outline, so we can start with our main session. So I need one from my candidate to read the questions for me and try to help me. Anyone interested to read the question?
What is
Okay. So today we'll be starting the September 2020 diet. So someone from my candidate, please help us by reading the question. And always you should read the question first and then the options, and this will give an idea from which system the question has come. And after that, we'll go through the main scenario. So at first read the lead question first, then read the options, and then go through the main question. So I think we can start now. Someone please continue reading the questions.
So may I do?
Yeah, please carry on.
Okay. Which of the following is the most appropriate investigation to establish the origin of the bacteria? A option is abdominal computerized tomography (CT), colonoscopy, endoscopic retrograde cholangiopancreatography (ERCP), orthopantomogram, and upper GI endoscopy. These are the five options. Now the question is: 69-year-old man is admitted with night sweats, weight loss, and anorexia. Over the past 3 months, he has hypertension and undergone dental extraction some 10 years ago. Although since then he has refused to see the dentist. His blood pressure is 132/88 millimeter mercury and his pulse is 85 beats per minute and regular. He has an ejection systolic murmur. There are crackles at the both bases. On auscultation of the chest, his abdomen is soft and non-tender with no muscles. On examination, hemoglobin is 9.1, white blood cells 12.9, platelets is 302, sodium 143, potassium 4.4, creatinine is 121, and on blood culture we are having Streptococcus sanguinis.
So what
Okay.
might be the answer here?
Colonoscopy?
Yes, because
Yes, exactly.
sanguine.
No. It shouldn't be colonoscopy. Okay, let's go back. Just look at here. The patient is admitted with night sweats, weight loss, and
Night
anorexia. The night sweats points towards pyrexia or
orthopantom.
fever, and there is also heart murmur. So we know that if a patient comes up with the features of fever plus heart murmur, the most likely diagnosis is the infective endocarditis, unless otherwise proved. So,
Infective endocarditis.
so fever plus heart murmur, the diagnosis is the infective endocarditis, and
Carditis
they have also given the name of the organism in the blood culture
of
here.
this.
This is the Streptococcus
Right.
sanguinis, and they are
Sanguine.
asking which of the following is the most appropriate investigation to establish the origin of the bacteria. So Streptococcus
Orthopoint.
sang yes, exactly. It should be OPG, the dental OPG. Okay, let me show you.
Okay.
What is the commonest organism for infective endocarditis? Anyone? The commonest organism for
Staphylococcus.
infective.
Staphylococcus. Staphylococcus aureus.
Yes, exactly. Staphylococcus aureus is the most common cause of
Aureus.
infective endocarditis, except one condition, except in case of early valve endocarditis.
Yeah.
From the time of valve surgery up to 2 months, staph
To
epidermidis would be the most common
epidermis.
organism. So remember E for epidermidis, E for early valve endocarditis. So epidermidis for early valve endocarditis. Other than this 2 months period, staph aureus is the commonest organism for infective endocarditis. So staph aureus, this is the most common cause of infective endocarditis, and particularly more common in acute presentation and IV drug abusers. So just remember A for aureus, A for acute presentation, and A for abusers. You can remember all of them with the help of A. And as the question here mentioned, is the Streptococcus sanguinis. So let's get back here.
Dr. Raj, we can't.
We can't hear you.
You can't hear me?
Yes.
The voice is
Kindly,
breaking in
please, all
between.
of them, please mute yourself. When I will be discussing, all of them, please mute yourself. So that would be easier for all of us. Yes, thank you. So just look at here, the Streptococcus mitis and Streptococcus sanguinis, these two groups, they are the subtype of Streptococcus viridans. And Streptococcus viridans, this is the normal flora of the mouth, and this is particularly found with the dental plaque. So if the question gives a hint regarding the either poor dental hygiene or a dental procedure or some sort of dental abscess or bad oral hygiene, then this points toward the Streptococcus viridans pattern, and the subtype is Streptococcus mitis and Streptococcus sanguinis. And since the origin is in the dental plaque or dental abscess, so we'll have to go with the dental OPG as the question here, as the question that has been presented here. And the coagulous negative staphylococcus, that is the staph epidermidis. I said earlier, E for epidermidis, E for early valve endocarditis. So from the time of surgery up to 2 months, staph epidermidis should be the most common organism. And after 2 months, the organism will move back towards the staph aureus. So for from the time of surgery up to 2 months, staph epidermidis should be the most common organism. Other than this, staph aureus should be the most common organism, and aurea, A for aureus, A for acute presentation, A for abusers. And if there is any hints towards either dental abscess or bad oral hygiene or dental procedure, then think of the Streptococcus viridans. And another one is the Streptococcus bovis. Streptococcus bovis. Streptococcus bovis has the subtype known as the Streptococcus caluliticus. So just see here, before bovis, after C comes the colorectal cancer. So if Streptococcus bovis is suspected, then we will have to go with the colonoscopy. So here Streptococcus sanguinis, this falls under the subtypes of Streptococcus viridans. And just look at here, refuse to see the dentist, he has undergone dental extraction. So this is related to her dental abscess, or this is bad oral hygiene. So we'll have to go with the OPG view. And colonoscopy should be in case of Streptococcus bovis. And if the colonoscopy comes out negative in case of Streptococcus bovis can be associated with the colorectal cancer. and also with the biliary tract pathology. So if the colonoscopy comes negative, we will have to go with the MRCP or ERCP as the next option. But if a patient is unsuitable for colonoscopy and organism suspected is the Streptococcus bovis, then in that case we should go with the abdominal CT. Okay. So for Streptococcus bovis, the first line is the colonoscopy. If colonoscopy comes negative, then go for MRCP or ERCP. And if the patient is unsuitable for colonoscopy, then go for abdominal CT. And OPG for the staph viridans and the subtype are the Streptococcus sanguinis. And upper GI endoscopy is not really suitable in case of infective endocarditis. So Streptococcus sanguinis as a part of normal mouth flora, and this has led to
Sorry,
the.
Dr. Raj,
Yes, please.
what
Any
you said
question?
about the what you said about the upper GI endoscopy?
I said
And then
the upper GI endoscopy is really not beneficial for the suspicion or for making the diagnosis of any organism of the infective endocarditis. Upper GI endoscopy won't reveal anything regarding the organism of infective endocarditis. Just look at here
Dr.
the
R?
Streptococcus. Yes, any question?
Yeah. Earlier we read like whenever we have to rule out this malignancy of the GI tract, we go for upper, in certain questions it's written like this, we go for the upper GI endoscopy when it comes negative. Then we go for lower GI endoscopy, and if there's nothing, we go for capsule endoscopy. So it's probably in case of upper GI endoscopy, we try to rule out the upper GI malignancy.
No, that will have a different scenario. This scenario is from the infective endocarditis, as we see from the scenario here. And they're asking
That's
about
what
the.
I'm saying.
Yeah,
That's
yeah,
what I'm saying.
yeah. In that case,
In case of galolyticus, yeah, in
yes,
case of bovis.
yes, in case of bovis.
Yeah.
Yes. And colonoscopy is the investigation of choice for Streptococcus galolyticus endocarditis, and we should go with the colonoscopy. B for bovis, then C for colon cancer, C for colonoscopy, and if the colonoscopy comes negative, we can go with the MRCP. Upper GI abnormalities aren't recognized cause of Streptococcus sanguinis bacterial infection. So let's revise again: colonoscopy for bovis and OPG for the staph viridans pattern. Okay, let's move on to the next
Sir,
question.
can you repeat when to proceed for ERCP and CT scan?
Okay. Suppose the organism suspected is the Streptococcus bovis. Okay, Streptococcus bovis. This is associated with two conditions. One is colorectal cancer, and number two, this is less frequent. The more frequent is the colorectal cancer. Less frequent is the biliary tract pathology. These two abnormality can occur in case of Streptococcus bovis organism. So at first go with the colonoscopy. The colonoscopy will reveal the colorectal cancer. But if the colonoscopy comes out negative, this will virtually rule out the colorectal cancer. In that case, we'll have to think that the biliary tract pathology might be present. In that case, we'll go with the MRCP if the colonoscopy comes negative. And if the patient is unsuitable for colonoscopy, there is contraindication to colonoscopy. Then for second line investigation, in order to rule out or find the colorectal cancer, we can go with the abdominal CT. Is that clear?
Yes, sir, it's clear.
Okay.
Thank you.
Okay. I'm repeating again. The organism suspected is the Streptococcus bovis. So at first go with the colonoscopy. If the colonoscopy is positive, then the diagnosis is colorectal cancer. If the colonoscopy is negative, we need to rule out the biliary tract pathology as well. So if the colonoscopy comes negative, go with the MRCP, not ERCP. ERCP is an invasive investigation. So we'll go with the MRCP. But if the patient is unsuitable to go for colonoscopy, then for the diagnosis or ruling out of the colorectal cancer, we can go with the abdominal CT. Okay, next one. Okay, next question, please.
Which of the following fits best with the mode of action of ticagrelor? Cyclooxygenase inhibitor, factor 10A inhibitor, fibrin inhibitor, glycoprotein 2B3A inhibitor, and P2Y12 inhibitor. 62-year-old man who has suffered an ST elevation myocardial infarction (STMI) is treated with a left anterior descending stent and is now taking combination of aspirin and ticagrelor. So now they are asking for the ticagrelor. So ticagrelor is like a clopidogrel. So it is
Yeah, exactly.
P2Y2 inhibitor.
So this is the straightforward question. They are asking about the mode of action of the ticagrelor. So ticagrelor is the P2Y12. Can you please mute yourself, doctor, after reading the question? Okay, thank you. So ticagrelor is the P2Y12 inhibitor, and they binds to the ADP receptor. This P2Y12 inhibition. This is mediated by the ADP receptor. This is known as the adenosine diphosphate, and this is also in short known as the ADP blockers. So there are also other drugs which causes inhibition of the P2Y12 inhibitor binding to the ADP receptor. Let's see.
क्लास चल रही है
Okay, just look at here. The ADP receptor inhibitor. They are the clopidogrel, pasupril, ticagrelor, and chiclopridine. You must have to remember the first three ones. The last one is not so much important, but the clopidogrel and ticagrelor, these two are the most important, and they are the ADP receptor inhibitors, and they causes inhibition of the P2Y12. So remember clopidogrel, ticagrelor, and pasupril. And regarding the COX inhibitor, so the NSIs are the non-selective COX-1 and COX-2 inhibitor, and the selective COX inhibitors are the COXIBs, either rofecoxib or the celecoxib. And factor XA inhibitor are the directly acting anticoagulant, like either fondaparinux, epixaban, or edoxaban, and they are the first line treatment uh, for any case of thromboembolic event, for any case of deep vein thrombosis, and also if a patient with atrial fibrillation comes up with the features of stroke. In case of male if the score is greater than 2, or in case of male if the score is greater than 1, and in case of female if the score is greater than 2, then the default first line choice of treatment should be the factor XA inhibitor or the directly acting oral anticoagulant. The fibrin inhibitor are also known as the direct thrombin inhibitor, or in short DTI, and you have the example like either dabigatran or bifalirudin, and dabigatran is also used in the management of DVT or atrial fibrillation plus stroke, filling the criteria. And the bifalirudin is used in the treatment of acute coronary syndrome. Then we have the glycoprotein 2B3A receptor inhibitor. This is very important for your exam. Can anyone tell me the example of glycoprotein 2B3A inhibitors?
FCG
Rufiban.
There are,
Rituximab,
yeah,
FCG
there are three. What are the others? Look at here. Abciximab, tyrofibin, and eptifabatide. All the three are the glycoprotein 2B3A receptor inhibitors, and they are used for the patient before going to the PCI, percutaneous coronary intervention. So ticagrelor is the P2Y12 receptor antagonist. They prevent binding to the ADP, adenosine diphosphate mediated P2Y dependent platelet activation and aggregation. The NSIs of the aspirin are the non-selective COX inhibitor of both COX-1 and 2, and the selective COX are the COXIBs. Factor XA inhibitors are the directly acting oral anticoagulant, fibrin inhibitor, and also the direct thrombin inhibitors. They are in short known as the GT. So just look at here, GTI, direct thrombin inhibitor. They are either dabigatran or bifalirudin, and the dabigatran is used in the management of deep vein thrombosis, also in case of atrial fibrillation plus stroke, and bifalirudin is used in the treatment of acute coronary syndrome. And glycoprotein 2B3 inhibitor, we just said, abciximab, tyrofibin, and eptifabatide. And they are used in some patient undergoing the coronary angiography. Is that clear, everyone?
yes, doctor.
Okay. Next one.
Yes.
Prasugrel is, Dr. Ahad, Prasugrel is preferred if you're considering
Yeah,
to get the
Pastest is usually
PCI done. Yeah, it's preferred.
P
Yeah,
for Pastest, P for preferred. In
yeah,
case of PCI,
yeah,
you can
absolutely.
remember
If
with
you're
the
planning to do that.
yeah, you can remember with the three P. P for Pastest, P for PCI, P for preferred. Okay, next one, kindly please read.
Which of the following is the best pointer towards the alcoholic liver disease? A option is elevated alkaline phosphatase, elevated alanine aminotransferase, elevated aspartame aminotransferase, elevated AST ratio ALT ratio, and elevated gamma glutamyl transferase. 54-year-old man is referred to the hepatology clinic for review. Although he claims that he only drinks 2 pints of beer per week, his wife tells you privately that he drinks considerably more. He has a blood pressure of 155/92 and his pulse is 80 beats per minute and regular. He has a number of spider nevi and is obese with a body mass index of 32 kilograms meter square.
So which of the following is the best pointer towards the alcoholic liver disease?
Elevated AST ratio, ALT ratio.
Yes,
Elevated
very
alanine
good.
aminotransferase.
Elevated ASTs to ALT ratio. What should be the ratio?
Ratio.
Be
What
more
should be
than
the
2 is
ratio?
to 1?
Greater than
Ratio.
More than 2 is to 1?
yes,
More than 2 is to 1?
yes, very good. It should
Ratio.
be
Yeah, two
more
ratio.
than 2:1. And the elevated alkaline phosphatase, this is suggestive of the obstructive pattern. And elevated ALT or elevated AST, these two are suggestive of the hepatocellular damage. And GGT also reflects the obstructive pattern. So elevated AST and ALT ratio. The ratio greater than 2, this will be the biggest pointer or the best pointer towards the alcoholic liver disease. So ASTs to ALT ratio is normally greater than 2. A ratio greater than 3 is strongly sensitive of the acute alcoholic hepatitis. If you go through the past medicine, this line is written. The ratio should be greater than 3. But in case of all other books, whether this is the Oxford Handbook of Clinical Medicine or Davidson or the Pastest, you will always find the ratio greater than 2. This indicates the acute alcoholic hepatitis. So AST or ALT ratio greater than 2. This indicates the alcoholic hepatitis. So AST-ALT ratio greater than 2:1 or greater, this will point towards the alcoholic liver disease. Alkaline phosphatase, this indicates cholestasis, that is the obstructive pattern. Elevated ALT and elevated AST, this indicates the hepatocellular damage. And GGT also reflects the obstructive pattern, and GGT may be elevated in case of significant alcoholic abuse, but this is only increased in 75% of the cases. The biggest pointer is the ASTs to ALT ratio greater than 2. Okay, next one.
Dr. Ahad, how do we, if all those values are given, how do we quickly diagnose whether it's a cholestatic picture or it's a hepatocellular picture?
Okay. The alkaline phosphatase will be significantly elevated, as well as the gamma glutamyl transferase in case of obstructive pattern. The ALT and the AST, these two will be either normal or there will be mild elevation, and there will be deep jaundice. The bilirubin will be significantly elevated in case of obstructive pattern. And in case of hepatocellular picture, the alkaline phosphatase and also the GGT, they will either remain normal or mildly elevated, and the ALT and AST will be significantly elevated. Is that clear? So just looking at the level of the alkaline phosphatase and GGT, if they are significantly elevated, this points towards the obstructive pattern. And if the ALT and AST are significantly elevated, this indicates the hepatocellular damage. Is that clear now?
Yeah, thanks.
Okay, next one, please. Continue, please.
So which of the following is the most appropriate treatment? Loperamide, metronidazole, mesalamine, ofloxacin, and prednisolone. 29-year-old woman has returned from the honeymoon in the Maldives and complains of intermittent diarrhea, abdominal bloating, and severe flatulence. She tells you she has been off her food since returning from holiday and has lost 2 kilograms in weight. Examination is unremarkable apart from mild abdominal distension. Hemoglobin is 11.9, white blood cells 8.1, platelet 181, sodium is 144, potassium is 3.4, creatinine is 118, and C-reactive protein is 52.
So this is a question from the infectious disease, and whenever question from the infectious disease come, we'll have to think of the incubation period, and there is a long list of incubation period. If the incubation period is greater than 7 days, then we'll have to think of the two differential diagnoses. One is the amoebiasis, and the second one is the giardiasis.
Yeah.
Yes.
Yeah, that's it, yes.
So how will you differentiate between the amoebiasis and giardiasis? In case of amoebiasis, there will be bloody diarrhea, and this predominantly occurs in case of Indian subcontinent. And the giardiasis will have the features of malabsorption, and the features of malabsorption are diarrhea, staturia, and weightless, and also there might be abdominal bloating or severe flatulence. I am repeating again: long incubation period plus bloody diarrhea, this points towards amoebiasis. Long incubation period plus features of malabsorption, this points towards giardiasis. So here the question is having a long incubation period, and the patient is having the features of malabsorption here. Look at here, the patient has intermittent diarrhea, abdominal bloating, and severe flatulence. So long incubation period plus features of malabsorption, the diagnosis is the giardiasis. So what's
But
the
only one strain of E. coli will, cause bloody diarrhea, right?
yeah
But E. coli's time period is small, less than 7 days.
yeah
Yeah,
the
only
E.
one
coli.
strain causes the bloody diarrhea. What about the other one?
Hemorrhagic strain is not good to cause the bloody diarrhea. And
Hem-
its incubation period is,
No, no.
yeah.
I'm asking,
Sure.
what about the non-bloody diarrhea causing this E. coli? How do we differentiate that from
okay.
giardiasis in the same incubation period?
So in case of traveler's diarrhea or in case of E. coli, there are two patterns. One is the one is associated with the impairment of the renal function, that will cause the hemolytic uremic
HUS.
syndrome, HUS. In that case, we will see the features of hemolysis here. So hemoglobin will be low, the platelets count, so there will be thrombocytopenia, and there will be impairment of the creatinine and also the potassium level. Here the creatinine level is normal, potassium level is normal, and there is no features of hemolysis. So this will virtually rule out the E. coli induced hemolytic uremic syndrome. Okay. So what should be the most appropriate treatment for giardiasis? Anyone?
Metronidazole.
Yes, very good.
Metronidazole.
Either go for
Metronidazole.
metronidazole or the tinidazole.
Metronidazole.
Yeah. So giardiasis occurred on holiday with intermittent diarrhea, abdominal bloating, and anorexia. This points towards the giardiasis. And the organism is the Giardia protozoa. This is the protozoal organism, and we'll have to go with either metronidazole or tinidazole. And metronidazole is the first line treatment, and this is often preferred. And you have to give the 7 days course of metronidazole.
Dr. Raj,
Yes, please.
can you give an overview of the incubation period along with the condition caused by the, according to the incubation period?
Okay, 1 minute. So look at here. Can you please mute yourself? There has been destruction in the background. Just please mute yourself. Yes, thank you. So look at here the incubation period. If this is greater than 7 days, this is either giardiasis or amoebiasis. Giardiasis will have the features of malabsorption. Amoebiasis will have the bloody diarrhea. If the duration is 48 to 72 hours, this is either due to Shigella or due to Campylobacter. And this Campylobacter is associated with the wedding meal, with the dairy products or with the meat products, and they often comes up with the renal impairment. So you will either get hyperkalemia or elevated creatinine in the blood picture. Shigella is associated with the child daycare. The outbreak of Shigella usually occurs in the child daycare. And when the diagnosis is when the incubation period is 12 to 48 hours, we can have either salmonella or E. coli. And E. coli, this causes the traveler's diarrhea. So in that case, you will get the history of traveling. And salmonella causes the enteric fever. So we'll get the feature similar to that of the typhoid fever. The patient will have the abdominal pain, and you can also get the rash, and there will be relative bradycardia. And 1 to 6 hours or the short incubation period, this is very important. The short incubation period is associated with two conditions. One is Staph aureus, and second one is the Bacillus cereus. In case of Staph aureus, the Staph aureus occurs in case of buffet display food products like the dairy food products or the products that are made from the milk or dairy, and the patient will have the vomiting. The vomiting will be the main features in case of Staph aureus. And in case of Bacillus cereus, they give the clue like either reheated fried rice or Chinese restaurant. So if this is Chinese restaurant or reheated fried rice, think of the Bacillus cereus. If the vomiting is more predominant, the food is displayed in the buffet restaurant, or there is history of taking the dairy or milk made products, then think of the Staph aureus. Is everything clear now?
Yes, doctor.
Sir, can you explain Campylobacter symptoms?
Campylobacter. Okay. So the Campylobacter jejuni infection, they usually points towards or give the history of the wedding meal. The wedding meal means you can either get the contaminated meat or contaminated dairy product, and the patient will have the elevated urea and creatinine level. I just said the Campylobacter jejuni infection. This is associated with some sort of renal impairment. So we'll get elevated urea and creatinine, and remember the contaminated meat, this is associated with the Campylobacter jejuni infection. They give the clue towards the wedding meal. And the treatment should be the macrolide, either azithromycin or the erythromycin.
And doctor, you mentioned previously that salmonella mostly common in the nursing care. So
Yeah.
salmonella for salmon.
Okay, look at here. The norovirus, they occurs in the epidemic form, and they usually gives this classical line. The patient will have the projectile vomiting and explosive diarrhea. So projectile vomiting and explosive diarrhea occurs in the epidemic form in a closed environment. Let's say in case of ship cruise inhabitants, this will have the diagnosis of norovirus. Salmonellosis, this occurs in the nursing home. The shigellosis will come up with the bloody diarrhea, abdominal pain, and this gives the points towards the child daycare. The Staph aureus is associated with the buffet restaurant display food products, cream or dairy products. They are made from the milk products. And Clostridium jejuni, they are usually the poultry or dairy products and also the contaminated meat. So is now everything clear? Can I proceed
Thank you, sir.
further? Okay.
Yes, doctor.
So please read the next question.
Which of the following is the most likely diagnosis? Allergic bronchopulmonary aspergillosis, aspergilloma, eosinophilic granulomatosis with cholangitis, invasive aspergillosis, and sarcoidosis. 41-year-old woman who works at a riding stable stubbles present to the asthma clinic with worsening symptoms. She is normally well controlled with twice daily inhaled Salmeterol fluticasone combination inhaler. Although over the past few months she has begun to cough much more and has noticed increase in her wheeze. She also has intermittent hemoptysis. Blood pressure is 135/84 and pulse is 70 beats per minute regular. There is generalized wheeze on auscultation of the chest. Hemoglobin is 12.2, WBCs are 11.1, eosinophils 3.1, platelets 307, sodium 142, potassium 4.4, creatinine is 10A. On chest X-ray, there is patchy areas of shadowing throughout both lung fields. Aspergillus precipitans is positive and total immunoglobulin IgE is 550. So now what is the diagnosis?
So this patient is having the features of asthma, now come up with the features of eosinophilia. And the aspergillus precipitant is positive, the total IgE is elevated, and the chest X-ray is showing the patchy areas of shadowing throughout the both lungs. So before solving this question, let me tell you another thing. Asthma plus eosinophilia. A patient coming up with the features of asthma, you go with the CBC. This shows the eosinophil count or eosinophilia. Then we'll have to think about the four differential diagnosis. So look at here, the asthma associated disorders associated with the eosinophilia. One can have the Sharp-Strauss syndrome or features of jar or pen, or in case of ABPA, allergic bronchopulmonary aspergillosis. We are having the two option here related to the elevated eosinophil count and also the eosinophilic granulomatosis with polyangiitis. This is also associated with the asthma plus elevated eosinophilia. So the patient is having the features of asthma plus eosinophilia plus aspergillus precipitant positive with elevated IgA level. So what might be the most likely diagnosis here? Anyone?
A. Allergic.
A.
Yes.
Yeah.
Yes, very good. So the aspergillus precipitant positive, the positivity of the aspergillus precipitant, the most likely diagnosis should be the allergic bronchopulmonary aspergillosis. And this is also suggested by the elevated IgE level. Why not aspergilloma? Aspergilloma is nothing but a fungal ball cavity. And in case of aspergilloma, you will,
X,
There
yeah,
will be a cavity
X-ray does
from
not
the
show
X-ray.
that.
yes,
There will
exactly.
be a
Yeah.
ball.
The chest X-ray in case of aspergilloma, they will show the cavitating lung. They will show the cavitating lung lesion, and the aspergillus precipitant will be negative in case of aspergilloma. Why not eosinophilic granulomatosis with polyangiitis? EZP or the Sharp-Strauss syndrome?
There will be any blood vessel disorder associated with the polyangiitis,
Yes, very good.
along with the asthma and the
Yes, and also in case of Sharp-Strauss syndrome, we'll get the features of mononeuritis, but
yeah.
there is no features of mononeuritis here, and also the Aspergillus precipitant would be negative. Always remember the Aspergillus precipitant is positive only in case of allergic bronchopulmonary aspergillosis, none in other option. And invasive aspergillosis, this occurs in the immunocompromised patient, and there will be systemic involvement, but the patient is immunocompetent here and there is no features of systemic involvement here. Sarcoidosis usually occurs in case of Afro-Caribbean patient, and the patient will have either features of hypercalcemia or there will be bilateral hilar lymphadenopathy. Nothing is suggestive here. The patient isn't from the Afro-Caribbean origin. There is no shin lesion here. There is no bilateral hilar lymphadenopathy here, and also the aspergillus precipitans and IG. This will be normal in case of sarcoidosis. So taking all things together, the most likely treatment here should be the allergic bronchopulmonary aspergillosis. So how will you treat this patient? Treatment for ABPA? Anyone?
Steroids.
Yeah.
Oral steroid.
Antifungal steroids.
Itraconazole, if steroids to
Combination. We'll have to give
yeah.
for the treatment of ABPA. We'll have to give the combination of oral steroid and also the antifungal itraconazole. And since the IgE level is elevated, if IgE level is elevated, then you can also go for the omalizumab. So ABPA, asthma with worsening symptoms of eosinophilia, inflammatory changes on the chest X-ray, and positive aspergillus precipitans. This points towards the allergic bronchopulmonary aspergillosis. Oral steroid plus itraconazole is the mainstay of treatment, and you can also give omalizumab in some patients since there will be elevation of the IgE level. Aspergilloma is nothing but a cavitating lung lesion, and this will show the fungal ball cavity, and the treatment should be surgical resection. The eosinophilic granulomatosis or polyangiitis, also known as the CSS, Sharkster syndrome, this will come up with the features of asthma with eosinophilia, and you will get the features of mononeuritis multiplex. Invasive aspergillosis occurs in immunosuppressed patient, and the patient will have the systemic involvement. And galactoman testing can be used to detect the aspergillus antigen, and voriconazole is the intervention of choice. And sarcoidosis, this occurs in the Afro-Caribbean patient. They usually comes up with the mild hypercalcemia, and you will also get the bilateral hilar lymphadenopathy.
جالك تمنى نقول لي إن aspergillosis دكتور عهد.
Galactoman testing, this can detect the aspergillus antigen only, nothing else. Okay. But the aspergillus precipita, this points more towards the allergic bronchopulmonary aspergillosis. Okay, next one, please.
Which of the following is the most appropriate next step? 2-week course of trimethoprim, intravenous urography, prostatic biopsy, recast in 3 months, and referral for the flexible cystoscopy. A 61-year-old man has come to the respiratory clinic for routine review of asthma. On review of his observation in clinic, you note that he has had dipstick positive hematuria, detected for the second time in the past 6 months. The presence of red cells was confirmed by the microscopy of the first sample. There was no protein present in either sample. He is completely well and his asthma is stable. Physical examination in the clinic is unremarkable. Hemoglobin is 11.9, white cell 9.2, platelet is 302, sodium 143, potassium 5.0, creatinine is 112, and PSA is 1 nanogram per milliliter. So what is the next appropriate step?
So if we look at here, this is the second episode, and the patient has come up with the dipstick positive hematuria, and this has been confirmed by the microscopy of the first sample, and the physical examination is unremarkable. So this indicates recurrent asymptomatic dipstick positive hematuria, or also known as the microscopic hematuria. So persistent plus microscopic hematuria, and if the in absence of other symptoms or asymptomatic cases, and if the age of the patient is greater than 55 years, then according to the NICE guideline, we'll have to rule out two conditions. The number one condition is the transitional cell carcinoma of the bladder. Number two is the renal cell carcinoma, and the first priority is with the TCC, transitional cell carcinoma of the bladder. I am repeating again. According to the NICE guideline, if the age of the patient is greater than 55, here the age of the patient is 61, and if the patient has recurrent asymptomatic microscopic hematuria, then at first we'll have to rule out the transitional cell carcinoma of the bladder. So in order to rule out the transitional cell carcinoma of the bladder, what should be the most appropriate step here? I'm making it easy for you to rule out the TCC. Yes, very good. Just directly look through the bladder with the help of flexible cystoscopy. The flexible cystoscopy, this will either identify or rule out the transitional cell carcinoma. So let me repeat again. According to the NICE guideline, if the age of the patient is greater than 55 years and the patient comes up with recurrent asymptomatic microscopic hematuria, everything other else is normal, exclude the transitional cell carcinoma first with the help of flexible cystoscopy. And just look at here, the prostate specific antigen is normal here, and there is no features of benign allergic prostate, or there is no features of LUTS. So it can be a case of benign prostatic hyperplasia or prostatic cancer, and no need to go for the prostatic biopsy. So persistent microscopic hematuria in the absence of other symptoms raises the possibility of the transitional cell carcinoma of the bladder, and the default choice of investigation should be to see the bladder with the help of flexible cystoscopy. So age of the patient greater than 55 years, patient coming up with persistent asymptomatic microscopic hematuria, rule out the transitional cell carcinoma with the help of flexible cystoscopy. And if the cystoscopy comes up negative, then we will have to go for the contrast CT. Okay, next one, please.
So, which of the following is the most useful next investigation? Colonoscopy, CT abdomen, mammogram, PET scan, upper GI endoscopy. A 67-year-old woman is referred to the oncology clinic for investigation of metastatic disease. She was referred for radiological investigations after presenting to her general practitioner with persistent lethargy. Her blood pressure is 132/82 millimeter mercury and pulse is 88 and regular. She is thin with a body mass index of 21. You can feel liver age on palpation of the abdomen. Rectal examination is unremarkable. On investigation, HB 9.1, MCV is 76, WBC is 9.9, platelet 380, sodium 144, potassium is 4.2, and creatinine is 122, ALT is 122, AST is 131, alkaline phosphatase is 295, and liver ultrasound, 3 large metastases within the right lobe of the liver. So what will be the investigation?
So the diagnosis here is almost given. There is 3 large metastases within the right lobe of the liver. So this is the case of hepatic metastasis, and this is also evidenced by the elevated alkaline phosphatase, and also there is derangement in the ALT and AST level. So deranged liver function test with the features of hepatic metastasis. So we'll have to find out the primary pathology here, and look at here. There is features of low hemoglobin, or there is features of anemia, and there is low MCB. So this indicates the microscopic pattern of anemia, and the patient, the BMI of the patient is 21 kg per meter square, and you can also feel the liver is. So this is a case of metastatic hepatic cancer. So at first we'll have to find the primary pathology, and some clues are given here. There is low hemoglobin and low MCD, but the rectal examination is unremarkable. So this will virtually rule out the lower GI tract. So we no need to go with the flexible rectoscopy or sigmoidoscopy, and then also there is no features of upper GI bleeding. Sorry, there is no features of upper GI pathology, so no need to go with the upper GI endoscopy as well. And we know that the most likely cause of the hepatic metastasis in the absence of upper or lower GI tract symptoms, the most likely cause is the right-sided colonic neoplasm. So in order to rule out, or in order to identify the right-sided colonic neoplasm, what should be the most useful next investigation here for right-sided colonic
Colonoscopy.
pathology? Which one?
Colonoscopy.
Yes, very good. We'll have to go with the colonoscopy in order to rule out the
Colonoscopy.
right-sided colon cancer here, because right-sided colon cancer is one of the most common cause of hepatic metastasis in the absence of upper or lower GI symptoms. This patient has,
Why not CT, Dr. Ahmad?
why not?
CT. CT. Why not CT?
Okay, why not CT? If we go with the CT scan of the abdomen, the patient will have significant risk of radiation. So often CT scan is not preferred in case of lower GI pathology or colonic pathology. The default choice of treatment should be the colonoscopy. As we said, in case of Streptococcus bovis, in order to detect the colorectal cancer, the first line investigation should be colonoscopy. Only if the patient is unsuitable for colonoscopy, then in that case we can expose the patient to radiation. Only in that case we will go with the CT scan of the abdomen. But the default of the first line investigation in case of colonic pathology is always the colonoscopy. Clear?
Yes, thank you.
Okay. This patient
Why
has
not PET?
PET is
How did you reach the right colon? I did not understand.
by going through the colonoscopy we can reach the right colon. Okay, the right
No,
colon.
no, no.
Sorry.
How did you know that it is in the primary is in the colon?
Okay, so number one, just look at here. There is no features of upper GI symptoms here. All the upper GI symptoms are absent here, and the rectal examination is also unremarkable. So it is more likely excluding the lower GI symptoms as well. So in the absence of upper or lower GI symptoms, if a patient comes up with the liver metastasis, the commonest primary is in the right-sided colon, and the right-sided colon cancer is often the primary pathology in the absence of upper or lower GI symptoms in case of hepatic metastasis. Okay, just look at here. This patient has microscopic anemia with abnormal liver function test and liver metastasis identified on the liver ultrasound scan. Given the absence of upper or lower GI symptoms, a right-sided colonic cancer is the potential cause of our presentation. So if there is no features of upper GI symptoms or no features of lower GI symptoms, patient come up with the features of liver metastasis, then the most likely primary pathology is in the right-sided colonic cancer. And the first line choice of investigation to rule out or to identify the colonic cancer is the colonoscopy. We'll only go to the CT scan if the patient is unsuitable for colonoscopy. If the colonoscopy is untolerated, mammogram won't reveal anything. And one doctor asked about the PET scan. PET scan is more advanced type of the PET scan is more advanced type of investigation. This is never the first line investigation. And since there is no upper GI symptoms here, so it's unlikely to go for the upper GI endoscopy. Is everything clear now?
Yes, doctor.
Okay. So how many have you joined? Only 29. So that means all of you haven't joined. Okay.
Dr. R, regarding the right-sided, presuming that it's right-sided, does it have something to do with the ulcerative colitis, something where we have, I just, because when we see the right-sided colon and the left-sided, why is it, why does the, why is it presumed that it's right-sided, just like the other doctor asked? Why not left-sided, or why not somewhere else?
Actually,
Why?
it's written in the textbook. Some kinds of memorization. Okay, if there is liver metastasis, since liver is in the right side, so most likely
Okay.
the most of the
Closest
part of
one.
the liver
All
is
right.
in the right side, so most likely they think that the
The
metastasis,
nearest possible.
yeah,
Okay.
the metastasis is more likely to be possible from the same side. So they often suggest the right sided colon cancer, not the left side.
Got it. Got it. Okay.
It is due to the anatomical position.
Yes,
It is
due to the
written in
anatomical
Davidson.
position.
Yeah, it's written in the Davidson, you can say.
Okay, next one.
So, which of the following antibodies are most specific for the likely diagnosis here? Anti-double-stranded DNA, anti-Jo1, anti-Me2, anti-nuclear, anti-smooth mucin. 42-year-old woman comes to the rheumatology clinic with progressive weakness. She is finding it increasingly hard to get up out of a low chair. comb her hair and climb the stair. She is not able to continue with her job as a guide at the local museum. She has no medical illness and takes no regular medication. Blood pressure is 118 80 millimeter and pulse 82 regular. You confirm 4-5 power, weakness affecting the proximal muscles of her upper and lower limbs. On investigation, HB is 11, white cell count is 10.2, platelet is 33, 339, sodium is 144, potassium is 4.3, creatinine is 98, TSH is 1.3, and CK is 1273. It is high. So now which of the likely diagnoses?
Okay, so this patient is having the features of proximal myopathy here, weakness affecting the proximal muscle with the progressive weakness. So features of proximal myopathy plus significantly elevated creatinine kinase. What should be the most likely diagnosis? Proximal myopathy plus elevated creatinine kinase.
Polymyositis.
Yes, exactly.
Polymyositis.
The most likely diagnosis is the polymyositis. And
Completely.
polymyositis, the most specific antibodies for polymyositis is the anti-SHO1 antibody.
Anti-Zo1 antibody.
Yes, anti-SHO1 antibody. This is mostly found in case of the polymyositis, and in some cases of the pulmonary fibrosis, you can also get the anti-SHO1 antibody. But the anti-SHO1 antibody, this is most predominantly and more specifically found in case of polymyositis.
We find it in dermatomyositis as well, but it's not
Yes, exactly.
specific.
Anti-SHO1 is also found in case of dermatomyositis, as well as anti-MI2 and also the ANA and the anti-MI2. The anti-MI2, this is more specific or the most specific for dermatomyositis. Anti-SHO1 can also be found in case of dermatomyositis, but remember, anti-SHO1 is more specific for polymyositis. Anti-MI2 is more specific for dermatomyositis. And since there is no skin involvement here, the diagnosis of the dermatomyositis is excluded here. And you can also remember polymyositis plus dermatological involvement. The most likely diagnosis is the dermatomyositis. But there is no skin involvement here. There is no Gottron's papule or some other signs here. So this is not the case of dermatomyositis. So it can be anti-MI2. ANA antibodies can be found in a long list of causes. And anti-smooth muscle, I said this is asthma. Asthma is found in case of AIAs, autoimmune hepatitis. Okay. So anti-double stranded DNA, this is specific for SLE. Anti-Jo1 is more specific for polymyositis. Anti-MI2 is most specific for dermatomyositis, and the smooth muscle, this is found in autoimmune hepatitis. So anti-SHO1 antibody are found in around 20% of the patient with polymyositis, and proximal myopathy plus Merkley elevation in creatinine kinase points towards the polymyositis. And since there is no features of dermatological involvement, so dermatomyositis is excluded here. And the steroid are the initial treatment of choice in case of polymyositis. Anti-dsDNA, this is specific for SLE. Anti-MI2 is specific for dermatomyositis, and the absence of skin rash, this will virtually rule out the dermatomyositis. ANA is elevated in long list of causes, and the asthma is found in case of AIAs, autoimmune hepatitis. Okay, next one, please.
Which of the following is the most likely diagnosis? Acute pancreatitis, cholecystitis, pancreatic pseudocyst, perforative duodenal ulcer, spontaneous bacterial peritonitis. 45-year-old alcoholic is reviewed in the emergency department. He has severe epigastric pain, vomiting over the past 12 hours. As well as the previous admission with acute pancreatitis, he has gatinitis for which he takes omeprazole. His temperature is 38.1, blood pressure is 95/82, pulse is 100 and regular. He is thin and very tender in the epigastrium with garden. Hemoglobin is 10.2, white cell count is 11.9, platelets 109, sodium is 139, Potassium is 5.2, creatinine is 143, amylase is 390, calcium is 2.55, and glucose is 6.9, alanine, ALT is 65, AST is 62, bilirubin is 8. Now, what is the diagnosis? As he is alcoholic, it should be get towards the control.
Anyone? What is the most likely diagnosis here?
Acute pancreatitis.
The patient is in shock. So it's
So
not
amylase is not very high, so it is acute abdomen,
SBP, SBP,
the patient is in shock, so it has to be something serious.
Yeah.
There's
SBP.
swelling.
Yeah.
And can we see the question again, Dr. Jahan?
Yes, please. Go on.
Question. We are not okay.
So the patient
So
has got
severe epigastric pain and vomiting, and then the patient has hypotension, right? So it has something to do with apogee. So here the option
Spontaneous bacterial
perforated
SBP.
perforated
It's
ulcer,
already mentioned
duodenal ulcer,
that
more than SBP.
Perforated DO?
Yeah, more than SBP. It points towards perforated duodenal ulcer.
pancreatic cyst.
Okay.
they have mentioned that she has a previous admission of with the acute pancreatitis. Now patient is in the hypotension along with the severe pain. The amylase level is not much raised. It can't be pancreatitis.
Okay. Thank you.
Cholecystitis yeah.
So let me explain. So just look at here. The patient has come up with the severe epigastric pain and vomiting, number one. Number two, there is features of shock here. The patient is having the hypotension and patient is having the tachycardia. And if we look at the blood picture, the hemoglobin is slightly low and there is thrombocytopenia. So there is low hemoglobin, there is thrombocytopenia. So we can assume that there might be some sort of mild bleeding in this patient. And the amylase level is mildly elevated here, and the calcium level is normal as well as the glucose level. So since the amylase level is slightly elevated here and also the calcium level is normal, so this will virtually rule out the acute pancreatitis, number one. Then let's go for cholecystitis. In case of cholecystitis, the patient usually comes up with the epigastric pain or the right-sided pain. But in case of cholecystitis, the bilirubin will be significantly elevated, and there will be some sort of hepatic dearrangement here. But the LT and AST level is almost close to the normal. So cholecystitis is also ruled out. Pancreatic cirrhosis. This is a chronic condition, and the patient will come up with the non-specific abdominal pain. The patient won't have the features of shock. The patient won't have the severe pain, and also in case of pancreatic cirrhosis, there will be no features of shock as well, and on abdominal palpation will get some sort of mass. So there is no mass in abdominal palpation. This is not a chronic case. The patient has come up with the serious features with the features of shock. So we have only two left. One is perforated duodenal ulcer and another one is the SBP. So the precondition for diagnosis of the spontaneous bacterial peritonitis is the features of ascites. And if we go for the tapping the ascitic fluid, the cell culture will show greater than 250. But there is no features of ascites here, so you can get the cell count here. So it can be a case of spontaneous bacterial peritonitis. And if we correlate everything with the perforated duodenal ulcer, it will fit perfectly. Let me show you. So mildly low hemoglobin with thrombocytopenia, meaning there has been some sort of mild bleeding, and mild bleeding can be
Dr.
explained.
Anand,
Yes, please.
the low platelet count suggests consumption of the platelets involved in clotting. Is that what you're referring to?
No.
what is the significance of low platelet count here?
The significance of low platelet count indicates that there might be some sort of bleeding, but if we go for the consumption coagulopathy, the DIC will be elevated, the
No, no,
APTT will be elevated.
so no, bleeding is signified by the low low hemoglobin, right? Platelet count being low in case of this acute bleeding, does it mean that the platelets which were there at the moment have got consumed? That's why it shows low platelet count.
Yes,
I'm not able to understand.
Thrombocytopenia can also be explained by that mechanism, but
Okay,
mostly the
okay.
low hemoglobin mostly
Yeah,
signifies
that's
the mild
evident.
bleeding here, and the thrombocytopenia can also be explained as you said there. That can also be absent here, and also we know that in case of perforated duodenal ulcer, we'll get the very tender epigastrium with features of shock, and the patient will have the severe epigastric pain. So the most likely diagnosis here should be the perforated duodenal ulcer. And I am repeating again in favor of SBP. In order to diagnose SBP, there has to be mass, there has to be ascites. And in the ascitic fluid, if the cell count is greater than 250, then it will indicate the SBP, spontaneous bacterial peritonitis. But since there is no ascites here, there is no probability of getting the cell count here, so it can be spontaneous bacterial peritonitis. Doctor, can you please mute yourself? There has been lots of. Yes, please. So the most likely diagnosis here should be the perforated duodenal ulcer. Is that clear, everyone?
Yes.
Yes, sir.
Yes, doctor. We missed the hemolytic picture. Hemolytic picture along with the hypotension will be always the perforation. So there is only one option mentioned is the perforation duodenal ulcer. So
Yeah, we can also explain it.
thank you, sir.
Given the evidence of shock here with hypotension, tachycardia, pyrexia, as well as epigastric pain and GERD, perforated duodenal ulcer is the most likely diagnosis. And the modest increase in amylase, this also fits with the diagnosis of the perforated duodenal ulcer, because we know that in case of perforated duodenal ulcer, there will be mild elevation of amylase. And in case of acute pancreatitis, the amylase level will be significantly elevated. And also acute pancreatitis is associated with the hypocalcemia, with the picture of hypocalcemia, but here the calcium level was normal. Cholecystitis usually comes up with the right upper quadrant pain, and this type of patient will have the elevated bilirubin level, and the patient isn't usually in the state of shock. Pancreatic cirrhosis, this is a chronic condition. The patient will have the grumbling epigastric pain or the non-specific epigastric pain with features of fever and epigastric mass. This epigastric mass will be palpable on abdominal examination. And the SBP, spontaneous bacterial peritonitis, this can only occur in the presence of ascites with elevated cell count. There was no features of ascites here, and the expected ascites is absent here. So it can't be a case of spontaneous bacterial peritonitis. Okay, next one, please.
Before we proceed, can I ask a question?
Yes, please.
Which is the best method to read a MCQ? Why are you first going for the questions, then you're going through the literature? Why is it so?
Okay, number one, there will be some question. They will directly ask what's the mode of action of this drug, and some question can only be answered by reading the last line, by just reading the lead question. No need to read the scenario. This will save you time in case of main exam. And when you first read the lead question, then go through the options here, you'll get an idea from which system the question has come, number one. And number two, you will have to think about only about 5 diseases. You will have to think here. So you are narrowing your you can easily narrow your conception, or you can narrow your mind regarding only those five diseases, or only those 5 topics. But if you start from the beginning, you have no idea from which system the question has come, and you will have to think about a wide range of diseases and a wide range of differentials. So it's always better to first read the lead question first, and then go for the option and then go for the scenario, because by reading the question you'll have some idea about who is the scenario might be, and you can also apply that thinking power while reading the scenario. Is that clear?
Thank you.
Okay. Okay, next one.
So, which of the following is the most likely cause of this of her skin changes? Dermatitis herpetiformis, erythema multiforme, pemphigus, pemphigoid, and scabies. No. 72-year-old woman is referred to the dermatology clinic with painful, blistering skin rash with multiple lesions over her body and affecting her mucous membrane. The blisters are flaccid and rupture to leave painful skin erosion. She tells you that the blisters appeared first in her mouth and then progressed rapidly. Examination reveals multiple flaccid blisters, skin erosion, and extension ulcers within the oral cavity. Hemoglobin is 10.
We can't
Now,
hear you,
subjects are
doctor.
322.
Repeat again,
Sodium is
please.
144. Potassium
Yes.
is 4.3. You cannot hear me?
Yeah. Now I can hear you. Continue.
Okay. Hemoglobin is 9. WBCs are 10.0. Platelet 322. Sodium is 144. Potassium 4.3. Creatinine is 104. And C reactive protein is 47. So now they're asking what is the diagnosis for this skin changes. So it is pemphigus vulgaris because she's old lady but affecting the mucous membrane. So most likely diagnosis pemphigus C.
Yes,
It
exactly.
cannot be pemphigoid.
Yes, thank you. Doctor, may I know your
Thank
name,
you.
please?
Rekha.
Okay, Rekha. So just look at here, the patient has come up with the blistering skin lesion. And if we look at the options here, among the 5 options, scabies isn't associated with the blistering skin lesion or the bullous skin lesion. And all the 4 can have the blistering skin lesion. So we will have to differentiate between the 4. And the bullous skin lesion or the blistering skin lesion, this is more predominantly found in 2 conditions. One is pemphigus vulgaris and another one is the pemphigoid. In order to differentiate between pemphigus vulgaris and pemphigoid, we'll have to look for the involvement of the oral mucous membrane. If the oral mucous membrane is involved, the diagnosis is pemphigus. If the oral mucous membrane is spared, the diagnosis is the pemphigoid. So bullous skin lesion plus involvement of the oral mucous membrane, diagnosis is pemphigus. Bullous skin lesion with no mucous membrane involvement, diagnosis is the pemphigoid. Erythema multiforme will come up with the target lesion, and this usually comes following the infection with either herpes simplex or with the mycoplasma. And remember, herpes simplex is the most commonly infection causing the erythema multiforme. And previously there was another condition called erythema multiforme major. At present, this is known as the Stevens-Johnson syndrome. Both Stevens-Johnson syndrome and pemphigus vulgaris, both of them are associated with the oral mucous membrane. But in case of Stevens-Johnson syndrome, there will be significant systemic involvement, and the condition of the patient will be very severe. But the pemphigus vulgaris, this won't come up with the features of systemic involvement. And the dermatitis herpetiformis is associated with the celiac disease. So they usually give the history of the either directly celiac disease, or they will give you a scenario pointing towards the celiac disease. And always remember, the dermatitis herpetiformis, they affect the extensor surface of the body. And there is another condition called atopic eczema or atopic dermatitis. They usually affects the flexural aspect of the body. So dermatitis herpetiformis, this will affect the extensor surface of the body, and the patient will have intensely itchy rash. So intensely itchy rash affecting the extensor surface of the body, the diagnosis is dermatitis herpetiformis. Intensely pruritic or papular rash involving the flexural surface of the body, the diagnosis is atopic eczema or atopic dermatitis. And since this is a case of bullous skin lesion, the patient is also old here, and there is involvement of the mucous membrane, so the most likely diagnosis should be pemphigus vulgaris. Okay, clear everyone?
Yes, doctor.
Okay, let me show you pemphigus vulgaris. What's the treatment for pemphigus vulgaris? Treatment for pemphigus vulgaris, anyone? Oral?
Steroid.
Yes, very good. Oral steroid. Oral steroid is the treatment for pemphigus vulgaris. Pemphigus vulgaris often presents with the mucosal blistering, also known as the oral mucous membrane involvement. And the Nikolsky sign will be positive in case of pemphigus vulgaris. And the pemphigus vulgaris, the patient will have desmoglein 3, or you can get the anti-TSG3 or G1. You will get anti-TSG3 or G1 in case of pemphigus vulgaris, and in case of pemphigoid, we will get the IgG deposition.
What you said for the treatment for vulgaris, it is antifungal.
No, oral steroid. It's the oral steroid.
Steroid, okay.
Yes, it's the oral steroid.
We can't hear you.
You can't hear me? Can you hear me?
Yes, doctor, you're
Yes,
right.
yes.
We can hear you now. We can hear you now. But initially, when you were just trying to, rule out the other answers, we lost you for a while.
Oh, sorry. Okay, I may repeat again. Okay. And there is another condition for bullous pemphigoid. The bullous pemphigoid, they will spare the oral mucous membrane. So there will be no mucous membrane involvement in case of bullous pemphigoid. And BP, in case of BP, the problem is the subepidermal blistering. This is the more deeper layer compared to the pemphigus vulgaris. In case of pemphigus vulgaris, the problem is in the dermoepidermal junction, in the superficial layer. For this reason, most of the bullous lesion in pemphigus vulgaris will be broken. And since the pemphigus bullous pemphigoid is more deeper layer in the subepidermal blistering, so the blister or the bullous lesion here, most of them will be intact, and we will get the antibodies against the hemidesmosomal protein BP180 and BP230. And the immunofluorescence will show deposition of IgG and C3 in the dermoepidermal junction. So I'm getting the quickly. Scabies is on the bullous skin lesion. Pemphigoid will have the bullous skin lesion, but there will be no mucous membrane involvement. Bullous skin lesion plus mucous membrane involvement. The most likely diagnosis is the pemphigus vulgaris. Erythema multiforme, we will have the target lesion. This is associated with the herpes simplex infection and also with the mycoplasma infection. There is another condition previously known as the erythema multiforme major, EMM. Currently, this is known as the Stevens-Johnson syndrome. The Stevens-Johnson syndrome and the pemphigus, both of them will have the mucous membrane involvement. But in case of Stevens-Johnson syndrome, there will be systemic involvement, and there will be no systemic involvement in case of pemphigus vulgaris. Dermatitis herpetiformis affects the extensor surface of the body. This is associated with the celiac disease. And in case of dermatitis herpetiformis, there will be intensely pruritic rash affecting the extensor surface of the body. There is another condition called atopic dermatitis or acute eczema. In that case, the flexural surface will be affected. Is that clear?
But erythema multiforme are also associated with the mycoplasma and pneumonia, right?
No.
Target lesions.
Yes. Erythema multiforme. Erythema multiforme is associated with the target lesion, and this erythema multiforme in most of the cases is associated with the infection called the herpes simplex infection. So history of herpes simplex infection plus features of target lesion. Think of the erythema multiforme. Doctor, can you please mute yourself? Okay. Okay, pemphigus vulgaris. So the patient will have the flaccid blister, and there will be mucous membrane involvement, and the antibodies will be directed against the anti-DSG3 and anti-DSG1, and the high dose steroid is the mainstay of treatment. dermatitis herpetiformis will affect the extensor surface of the body. This is associated with the celiac disease, and anti-TTG might be positive in case of dermatitis herpetiformis. Erythema multiforme will come up with the target lesion, and the most likely organism is the herpes simplex in most of the cases. In some cases, there might be mycoplasma. So if a question comes regarding the erythema multiforme, and they ask about the organism and both of the option, herpes simplex and mycoplasma is present, then the answer should be herpes simplex. Pemphigoid won't have the mucous membrane involvement. Scabies is something else. Okay, next one, please.
Excuse me, sir. Someone from the text is saying Neha Sharma to unmute her.
Okay, Dr. Neha Sharma.
Maybe you have muted her. She's saying to unmute.
Okay, continue. Next question.
So, which of the following is the most likely underlying diagnosis? Autoimmune hemolytic anemia, B12 deficiency, Felty syndrome, J6PD deficiency, and this hereditary spherocytosis. So, 29-year-old man presents to the clinic for review. He has suffered from increasing lethargy, intermittent diarrhea over the past few months, underwent splenectomy, and some 10 years ago tells you his brother and father have also had their spleens removed. Sorry. His blood film shows number of red blood cells containing Howell Jolly bodies. Okay.
So this is
So
an
what is
easy
the
question.
diagnosis?
So look at here. He underwent splenectomy. His brother and his father, they also underwent splenectomy. So he has been affected. His brother is affected. His father is affected. So this is an autosomal dominant condition. All the generation have been affected here. And the blood film shows the Howell Jolly bodies. The Howell Jolly body is nothing but the remnant of the RBC, and this remnant of the RBC is removed or washed out from the body with the help of the splenectomy. This Howell Jolly body will be removed from the body with the help of spleen. But since there is splenectomy, so there is no working of the spleen here. So the remnant of RBC has been remaining in the body, and this has given rise to the Howell Jolly body. So what should be the most likely diagnosis here?
Hereditary spherocytosis.
Yes, very good.
Hereditary spherocytosis.
Yes, excellent, very good. Hereditary spherocytosis. So, this is an autosomal inheritance. This follows the autosomal dominant condition, and often this type of patient will come up with the features of hemolysis, and also with the risk of gallbladder disease, with the gallstone. So in order to counter the gallstone, and also to reduce the risk of hemolysis, we'll have to go with the splenectomy, and for this reason the patient has also been treated with the splenectomy. And the problem, if we go for the if we go further into the cell membrane defect, the defect is in the spectrin and anacrin level. And autoimmune hemolytic anemia, patient with autoimmune hemolytic anemia will have the direct agglutinin test positive. Vitamin B12 deficiency, this will have the features. This patient will have the elevated MCB level. Felty syndrome. Felty syndrome is associated with the
Sorry,
feature.
Doctor. What you said about the autoimmune hemolytic anemia?
In case of autoimmune hemolytic anemia, the that test will be positive, meaning the direct agglutinin test will be positive. Okay. And Felty syndrome is usually associated with the rheumatoid arthritis, and the patient will have the features of hypersplenism, and there will also be neutropenia. And G6PD deficiency, just remember G6PD deficiency, this is associated with the Jane's body or the Haynes body. If there was Haynes body, the diagnosis would be G6PD deficiency, and Howell-Jolly body plus features of autosomal dominant inheritance pattern with the treatment with the splenectomy, the most likely diagnosis here should be the hereditary spherocytosis. Hereditary spherocytosis carries an autosomal dominant inheritance pattern in 75% of the cases. His brother is affected, and in his father, indicating the autosomal dominant pattern. And problem is in the spectrin and anacrin level. And this patient often has the features of hypersplenism and also increased risk of gallstones. So we'll have to ultimately undergo the splenectomy. And G6PD deficiency, this in this case we will find the Haynes body. Okay, next one please.
Which of the following is the most appropriate way to treat her lupus? Belimumab, continued hydroxychloroquine, azathioprine, methotrexate, and mycophenolate mofetil. 52-year-old woman who has systemic lupus erythematosus comes to the clinic for her routine appointment. Current medication include hydroxychloroquine for control of the lupus-related joint symptoms. Over the past 2 months, she has felt increasingly tired. Her blood pressure is 149/89 and pulse is 74 and regular. Her joint symptoms appear under control. Hemoglobin is 10.8, WBCs are 8.7, platelets are 332, sodium 143, potassium 4.7, and creatinine 145, up from 115 over the past 3 months. Urine protein double plus and blood is 2 plus. Which of the following way to treat her lupus?
So what's the diagnosis here? The diagnosis is already given here. Just look at here. This patient has come up with the features of SLE, and there is also features of joint involvement here, and there is mild derangement in the renal function. So this is a case of mild mild lupus nephritis. So what should be the most appropriate way to treat her lupus nephritis? Anyone for mild case of lupus nephritis? Okay, look at here. Okay, look at here. If the patient comes up with isolated features of SLE, no involvement of renal function, meaning there is no lupus nephritis, only SLE, then the first line treatment should be hydroxychloroquine. And the methotrexate can be used as an alternative to hydroxychloroquine, especially if the patient has the joint involvement. So isolated SLE, the first line treatment is hydroxychloroquine or the methotrexate. And if the patient does not respond to hydroxychloroquine, then we'll have to go with the belimumab. Belimumab is the choice of drug when the patient with SLE doesn't respond to the conventional drug like hydroxychloroquine or methotrexate. Now comes up with the lupus nephritis. So SLE plus renal impairment indicates the lupus nephritis. So if a patient with lupus nephritis comes, then we will have to first see whether there is mild to moderate renal impairment, or there is severe or life-threatening lupus nephritis, or there is features of RPGN. If there is mild lupus nephritis, then the first line treatment should be mycophenolate mofetil. And if the patient doesn't respond to mycophenolate mofetil, we will have to add the cyclophosphamide. But if initially the patient comes up with the life-threatening lupus nephritis or pieces of RPGN, then directly we will have to go with the cyclophosphamide. So if we get back to this question, so this is a case of lupus nephritis, and there is only mild renal impairment here. So the most likely treatment should be mycophenolate mofetil. And as I said, the hydroxychloroquine is only the treatment if there is isolated features of SLE, no renal impairment. The methotrexate can be used as an alternative to hydroxychloroquine if the patient with SLE does not respond to methotrexate or hydroxychloroquine, then we should go for belimumab. But if there is features of lupus nephritis, we have two choices. One is the mycophenolate mofetil, another one is the cyclophosphamide. If there is mild renal impairment, then go for mycophenolate mofetil. If there is severe renal impairment or life-threatening renal impairment or features of RPGN, rapidly progressive glomerulonephritis, then go for the cyclophosphamide. So since there is mild renal impairment here, so we'll go with the mycophenolate mofetil. Clear, everyone?
Yes, doctor.
Okay.
Yes, doctor, yes.
This is the mycophenolate mofetil, and here the dose is given. The dose is important for part 2, not for part 1. If you wish, you can remember, and if you wish, you can forget it. Okay, next one, please.
So, which of the following is the most likely cause of her U waves? 48-year-old woman is admitted to the emergency department following a collapse at work. By the time she is admitted to the department, she has regained consciousness and has a Glasgow coma scale.
We can't hear you, doctor.
You note U waves are present on the ECG. Which of the following is the most likely cause for the U waves? So U waves present in the hypokalemia. For hyperkalemia, it is the tall T10 waves.
Okay. So if the ECG changes show the U wave, then you will have to think that all the metabolite or the electrolyte present in the blood, all of them will be down. So U wave meaning all of them will be down. So you will get hypocalcemia, you will get hypokalemia, you will get hypomagnesemia, and you will also get the hypothermia. So among the options here, hypothermia and hypokalemia, these two are associated with the U waves. And just for remember, hypercalcemia, this is associated with the GF. So we'll have to decide whether this is the case of hypokalemia and hypothermia. So just as I said, both of them is associated with the U wave, but remember the hypokalemia, this is predominantly associated with the U wave, and the hypothermia is predominantly associated with the J wave. Hypothermia is associated in some cases with the U wave, but mostly this U wave is associated with the hypokalemia. And also look at here, the patient has come up with the features of collapse. So the collapse can be explained with the help of hypokalemia. So features of collapse plus U wave. So the most likely cause of our U wave should be the hypokalemia. Okay, look at here. Hypokalemia is a well-recognized cause of US, and as I said you earlier, U wave means everything, every component, electrolyte component in your blood will be down. So you'll get hypocalcemia, hypomagnesemia, hypothermia. Everything will be low, and there is only one only one exception. That's the ICP, the raised intracranial pressure. Everything else will be low. Hypocalcemia, hypomagnesemia, hypothermia, but the mostly the hypokalemia, or this is also known as the pushing effect. This pushing effect, the patient with hypokalemia will have the U waves. Let me show you. So this is the ECG picture for hypokalemia and hypokalemia. Remember, in case of hyperkalemia, there will be pulling effect. So there will be peak T wave, there will be P wave flattening, there will be PR prolongation, there will be white QRS complex, followed by the sine wave, and in case of hypokalemia, there will be pushing effect, meaning everything will be down. So there will be prominent U wave, there will be ST depression, T wave invasion. So everything down indicates the hypokalemia or the pushing effect, and the up or the pulling effect occurs in case of hyperkalemia. And you can also remember the level, but the level I will discuss in another diet in details. Okay, next one please.
Which of the following is the primary cause of her thyrotoxicosis? Anti-myeloperoxidase antibodies, glycosaminoglycan deposition, long-acting thyroid stimulating antibodies, release of steroid thyroxine, and toxic adenoma. 39-year-old woman comes to the endocrine clinic for review. She has lost 5 kg in weight over the past 2 months. She has palpitations and has been increasingly anxious. Her blood pressure is 108 millimeter mercury. Pulse is 98 beats per minute regular. She has a smooth goiter which is mildly tender on palpation, and a fine tremor at rest. Her TSH is less than 0.05. What is the primary cause of thyrotoxicosis?
So this patient has come up, the TSH level is low here, indicating this is a case of thyrotoxicosis or hyperthyroidism. The patient has come up with the smooth goiter, which is mildly tender. So the most likely diagnosis here should be the Graves' disease. So what's the primary cause of thyrotoxicosis in case of Graves' disease? Anyone? Graves?
TSH receptor antibodies produced by plasma cells.
Yes, very good. Okay, look at here. The Graves' disease is predominantly associated with the TSH receptor antibody, and this is the long-acting thyroid stimulating hormone receptor antibody. The long-acting TSH receptor antibody, this is associated with the Graves' disease, and there is also another antibody known as the anti-TPU antibody. Anti-TPU antibody is associated with the two conditions. One is the Graves' disease, another one is the Hashimoto thyroiditis, and the more predominance with the Hashimoto thyroiditis. But how will you differentiate if a patient comes with anti-TPO antibodies? The patient with Graves' disease will come up with the features of thyrotoxicosis, okay, and the patient with hypothyroidism will come up with the features of hypothyroidism. So if you find anti-TPU antibody positivity, then you will have to look whether the patient has the features of thyrotoxicosis or the patient has features of hypothyroidism. If the picture is of thyrotoxicosis, this is Graves' disease. If the feature shows the hypothyroidism, this is the Hashimoto thyroiditis. And also remember, anti-TPU antibody, this is more specific for Hashimoto thyroiditis. Long-acting TSH receptor antibody, this is more specific for Graves' disease. So since the scenario is from the Graves' disease, so long-acting TSH stimulating antibody, this should be the primary cause of our thyrotoxicosis. Why not toxic adenoma? In case of toxic adenoma, there will be single node, there won't be the smooth goiter. And the glycosaminoglycan deposition, this occurs in case of thyroid eye disease, or this is also known as the Graves ophthalmopathy, but there is no features of Graves ophthalmopathy here. And anti-MPU antibody, which condition is associated with the anti-MPU antibody? Anyone? Anti-MPU antibody? Anti-MPU antibody is associated with the microscopic polyangiitis and also with the CSS, Charles syndrome, okay? Anti-MPU antibody positivity is found. Number one is in the microscopic polyangiitis, which comes up with the features of renopulmonary symptoms or syndrome, and also the Charles syndrome or eosinophilic polyangiitis with granulomatosis. So stimulating TSH receptor antibody, this is the primary cause of thyrotoxicosis in a patient with Graves' disease. And anti-MPU, this is found in MPA, microscopic polyangiitis, and also in CSS. And just to discuss earlier, anti-TPU antibody, this is found in both Hashimoto thyroiditis and also in Graves' disease. And Graves' disease will have the features of thyrotoxicosis. Hashimoto thyroiditis will show the picture of hypothyroidism. The glycosaminoglycans, the deposition occurs in the retroorbital region. This is associated with the Graves ophthalmopathy or TED, thyroid eye disease. Toxic adenoma will have the single mass, and the mass will be nodular, not the diffuse goiter. Okay, everyone clear?
Yes, doctor.
Okay, next one.
Yes.
So, anyone else can read? I'm having flu now.
Okay, please, anyone else, please continue. Another one.
Thank you.
Which of the following is likely to be the most useful in controlling his headache over the long term? A. Lithium, prednisolone, sumatriptan, trigeminal nerve blockade, verapamil. Scenario: a 32-year-old man comes to the clinic for review. He has suffered from increasing headaches over the past 10 weeks, typically at night, occurring 1 to 2 hours after he goes to sleep. The headache always comes on the left hand side of his head and typically lasts between 45 and 90 minutes. He has staring conjunctival injection and facial flushing. At the time of the attacks, attacks occur on average 3 times per day. Neurological examination in the clinic is normal.
So this patient is having the unilateral headache. Okay, look at here. So the patient have. Yes, carry on, carry on.
Which of the following is likely to be the useful in controlling his headache over the long term? Lithium, prednisolone, sumatriptan, trigeminal nerve blockade, and verapamil.
I'm hearing the echo. Someone else is hearing the echo as well.
Yes, doctor. I think somebody is using two devices at the same time.
Kindly please use only single device, not two. Okay, now it's clear. Okay, look at here. The patient has come up with the features of unilateral headache, and the gender is important in case of headache. And the gender is given as a male gender, so male gender coming up with the features of unilateral headache. And the tearing, conjunctival injection, facial flushing. This indicates the sympathetic activation, and neurological examination is normal. So most likely there is no neurological symptoms or neurological pathology here. So male patient coming up with the features of unilateral headache with sympathetic activation. The most likely diagnosis here is the cluster headache. And we know that for controlling his head over the long term, or that means for the prophylaxis of the cluster headache, we go with the verapamil. And for the acute treatment, we go with the 100% hyperbaric oxygen followed by the sumatriptan, subcutaneous sumatriptan. And also remember the subcutaneous sumatriptan, this is also used in the acute treatment of the migraine patient. So for acute treatment in case of cluster headache, we will go with the 100% oxygen followed by sumatriptan, and the prophylaxis is with the verapamil. Okay, next one, please.
Which of the following is the most likely diagnosis? Acute schizophrenia, depression, drug induced psychosis, schizoid personality disorder, viral encephalitis. A 19-year-old student is brought to the emergency department by the police. He is studying maths at the local university. His flatmate called the police after he had locked himself in his room for 3 days and had lined it with silver foil to guard against the secret police transmitting thoughts into his brain and listening to them. He told them because he had seen a red car at the end of the street, he knew this was going to happen. He has not washed or changed his clothes for the past week, and he has been smoking increasing amount of cannabis. He refuses physical examination and to have blood taken. Which of the following is most likely diagnosis? Acute schizophrenia, depression, drug-induced psychosis, schizoid personality disorder, viral encephalitis.
So this patient is having the long history of the taking the cannabis drug. And also look at here, listening to them. This is known as the auditory hallucination. Transmitting thought into brain. This is known as either thought broadcasting or thought persecution, or also known as the thought insertion. And seen a red car at the end of the street, he knew this was going to happen. This indicates the delusional perception. So delusional perception plus thought disorder with long history of cannabis. The most likely diagnosis here is the acute schizophrenia. Okay, the most likely diagnosis here is the acute schizophrenia. So how will you differentiate between acute schizophrenia and cannabis induced psychosis? Anyone? How will we differentiate between the cannabis induced psychosis and with the acute schizophrenia?
Thought insertion here, the broadcasting.
Yes, very good.
And also,
Okay, look at here. The duration of cannabis can also lead us to differentiate between the cannabis-induced psychosis and also the acute schizophrenia. In case of acute schizophrenia, the patient will have the history of taking the cannabis for a longer duration of time, and suddenly they will increase the amount of cannabis, and the patient will come up with the features of thought insertion and also with the delusional perception. But in case of cannabis induced psychosis, the patient will have a short history of taking the cannabis, just only 1 day or 2 days, and they will take at a very higher dose, and the patient won't have the features of thought transmission or thought broadcasting. But the good point is that the treatment for acute schizophrenia and also cannabis induced psychosis is the same. Can anyone please tell me the treatment for acute schizophrenia?
Yes, Peridone.
Yes, it's the risperidone. What are the other conditions where risperidone should be used? Okay, I'm showing you 4 conditions. Try to memorize all of them, and these 4 conditions will be shown again and again. But the bad luck is that often the candidates forget this. So the treatment for acute schizophrenia or cannabis-induced psychosis or Tourette syndrome or delusional parasitosis. In all the 4 conditions, the first line treatment is always the risperidone, and the second line treatment is the olanzapine. And you'll have to remember one very important point regarding olanzapine. Olanzapine is associated with the weight gain. So schizophrenia, cannabis psychosis, Tourette syndrome, delusional parasitosis. In all of the 4 conditions, the first line treatment is the risperidone. Risperidone is the atypical antipsychotics. So acute schizophrenia, so you can treat the you can treat the patient by giving the risperidone. Okay, next one.
Which of the following is the most likely cause of his low measured oxygen saturation? Increased dead space, increased methemoglobin, intrapulmonary shunting, poor peripheral perfusion in his finger, ventilation perfusion VQ mismatch. A 34-year-old man comes to the emergency department with shortness of breath and a productive cough with purulent sputum over the past 24 hours. He is usually well and takes no regular medications. His temperature is 38.9 degrees Celsius, blood pressure 105/80, and pulse 95 and regular. Oxygen saturation is 91% on air. There are signs of consolidation at the right base on the auscultation of the chest. Investigations: hemoglobin 14.3, white blood cells 17.1, platelets 372, sodium 144, potassium 4.3, creatinine 102, C reactive proteins 231, X-ray findings right lower lobe consolidation.
Yes, very good. So what's the diagnosis here? Tell me the diagnosis first.
It's pneumonia.
Yes, very good. That's a case of pneumonia because there is features of consolidation with elevated CRP, with leukocytosis, with the features of raised temperature, and also the tachycardia, and also the shortness of breath and productive cough with the purulent sputum. So the diagnosis here is confirmed. This is a case of pneumonia or pneumonic consolidation. And always remember, in case of pneumonia or pneumonic consolidation, the low measured oxygen saturation, the pathophysiology of low measured oxygen saturation in case of pneumonia can be explained by 2 conditions. One is the interpulmonary shunting, and another one is the VQ mismatch. All the other 3 is not associated with the low measured oxygen saturation. So how will we differentiate whether this is due to interpulmonary shunting or VQ mismatch? And to differentiate, we'll have to look for the duration. If the duration of the pneumonia is limited to 1 to 2 days, then the primary pathology is due to intrapulmonary shunting. And if the duration is within weeks, 1 week or 2 weeks, then the most likely pathophysiology is due to the VQ mismatch. So let's get back to the question. Shortness of breath, productive cough with purulent sputum over the past 24 hours. So this is limited to 1 to 2 days. So the pathophysiology that can explain is the intrapulmonary shunting. And if the patient came after 1 week or 2 weeks, then VQ mismatch would be the answer. So short duration or early pneumonia, this is associated with the intrapulmonary shunting. And if the patient comes in the late phase, after 1 or 2 weeks, and then the VQ mismatching should be the pathophysiology. So for acute presentation, 1 to 2 days, interpulmonary shunting. For subacute presentation, this is the VQ mismatch. Clear, everyone?
Yes.
Yes,
Okay.
sir.
Okay, next one.
Doctor,
Which of the
Yes, please. Any
just a
question?
moment. Yeah. In the intrapulmonary shunting, there will occur this vasoconstriction, right? And is that how it occurs? The vasoconstriction in the affected area, and so that the blood flow occurs
No.
to the. What is the pathophysiology here?
No, sir, I think the shunts develop between the pulmonary
Yes, yes,
circulation,
yes.
which
The development of shunting is responsible for the low measured oxygen saturation. Okay.
Could you please explain this a little bit?
Okay, let me get back here. Intrapulmonary shunting occurs early in the pneumonia, and this is thought to be responsible for hypoxia occurring early in the disease. This is where blood flow is preferentially directed to the consolidated area of the lungs where the oxygen diffusion capacity is the poorest, and the blood flow is actually reduced to the areas of the lung where the gas exchange is much better. So this is due to the development of the shunting. This is not related to the blood flow, because when the blood flow is. Yes, any question?
Doesn't the vasoconstriction occur in the affected area, so the blood flow and consequently the gases exchange occurs in the unaffected area?
So basically, what happened? The gases exchange decreases, so
Yes,
there will be more
exactly.
accumulation of carbon than the oxygen. So because of that, there will be low saturation level.
Yes,
So gases
exactly.
exchange. I hope it's clear. No.
Okay, next one, please.
Which of the following human leukocyte antigen subtypes is this patient most likely to have? BO7, B27, B51, DR3, DR4. A 32-year-old woman, originally from Turkey, presents to the clinic for review. She suffers from recurrent oral and genital ulceration and arthritis. She had 2 episodes of anterior uveitis in the past few months. She suffered from a left below knee deep vein thrombosis some 3 years earlier. Examination reveals a blood pressure of 122 by 82 and a pulse of 72 per minute and regular. She has aphthous ulcers in the mouth. She has a body mass index of 21. You note a rash on both shins consistent with erythema nodosum. Investigations HB 10.2, white blood cell count 8, platelet 321, sodium 144, potassium 4.9, creatinine 120, C-reactive proteins 52.
So what's the diagnosis here?
Basics.
Yes, very good. So patient with Turkish or the Mediterranean origin coming up with the features of erythema nodosum and also the features of arthritis. The most likely diagnosis is the Pastest disease. And Pastest disease is also known as the oculo-oral genital syndrome. So there will be recurrent ocular lesion, there will be recurrent oral and genital ulceration, and they comes up with the Turkish, and often the patient present in their 30s, in the age group of 30. So the most likely diagnosis here is the Behçet's disease, and Behçet's disease is associated with the HLA-B51. And HLA-B27, this is associated with the seronegative arthritis. Seronegative arthritis means all the seronegative arthritis means ankylosing spondylitis, reactive arthritis, and also the enteropathic or IBD related arthritis. All of them will have the HLA-B27, but the HLA-B27 in Mrcp part 1 exam, uh, mostly they give the either ankylosing spondylitis or the reactive arthritis. DR3 is associated with which condition? This is associated with the myasthenia gravis,
diabetes.
Hashimoto thyroiditis, and also with the PSC. DR3 is with the PSC. Okay, is there clinical
So
signs?
diabetes also, na?
Type 1 diabetes is usually associated with the HLA-DR4, not DR3. Okay, it's associated with the DR4.
Okay.
Sorry. So look at here. The narcolepsy and the Guth-Pascher syndrome, this is associated with the HLA-DR3. The celiac disease, this is associated with HLA-DQ2 or DQ8. And HLA-DR3, this is predominantly associated with the Stevens-Johnson syndrome, primary biliary cirrhosis, dermatitis herpetiformis, and also with the myasthenia gravis and the Hashimoto thyroiditis. And as you said, the type 1 diabetes, autoimmune thyroid disease, and the rheumatoid arthritis, these are usually associated with the DR4. So SLA-B27, this is associated with the Behçet's disease, and the patient will have the oculo-oral genital manifestation with increased risk of thrombosis with erythema aneurysm, usually Turkish origin or Mediterranean origin, and the patient usually present within their 30s, age will be around 30 to 40. HLA-B27 with the seronegative arthritis, HLA-DR3 with the myasthenia gravis, Hashimoto thyroiditis, BSC, and DR4 with the rheumatoid arthritis, type 1 diabetes, and autoimmune thyroid disease. Okay, let's check, is it recording or not? Yeah, it's recording. Okay, next one, please.
Which of the following would you expect to find on cardiovascular evaluation? Elevated jugular venous pressure on physical examination, left bundle branch block on electrocardiogram, left ventricular failure, right bundle branch block on ECG, right parasternal prominence. A 26-year-old woman comes to the cardiology clinic for review. She has been referred by her general practitioner with a murmur suspicious of tricuspid regurgitation and a provisional diagnosis of Epstein anomaly. Which of the following would you expect to find on cardiovascular evaluation? Elevated jugular venous pressure on physical examination, left bundle branch block on ECG, left ventricular failure, right bundle branch block on ECG, right parasternal prominence.
So the diagnosis, the provisional diagnosis is given here. This is a case of Epstein anomaly, and always remember Epstein anomaly, the pathology is always in the right. This is the atrialization of the right ventricle, and the patient will have the features of right bundle branch block. So right bundle branch block on ECG, this is suggestive of the Epstein anomaly, and Epstein anomaly is also known as the atrialization of the ventricle in the right side. So when comes the topics Epstein anomaly, always think of the right side. Right bundle branch block, right ventricular atrialization of the right ventricle. RBBB, this is associated with the Epstein anomaly. And this is also the malformation of the tricuspid valve and the right ventricle. The alternate name is the atrialization of the ventricle. Okay, next one, please.
Which of the following is the most likely cause of her delayed puberty? Androgen insensitivity syndrome, hypogonadotrophic hypopituitarism, Liddle syndrome, primary ovarian failure, Turner syndrome.
Doctor, what's your name?
Dr. Minam.
Okay, carry on.
An 18-year-old woman comes to the endocrine clinic for review. She attends with her mother and they are concerned that she has not entered puberty. Her only other complaint is that she is unable to smell. Her blood pressure is 122/78 and her pulse is 70 and regular. Her body mass is 22. You note that she has a long arm span, no axillary hair, sparse pubic hair, and minimal breast development. Investigations: hemoglobin 13.6, WBC count 7.5, platelets 240, sodium 142, potassium 4.2, creatinine 99. Which of the following is most likely to cause her delayed puberty? Androgen insensitivity syndrome, hypogonadotropic hypopituitarism, Liddle syndrome, primary ovarian failure, Turner syndrome.
So what's the diagnosis here?
It's the hypogonadotropic
Hypogonadism.
hypogonadism, Coleman's.
Hypogonadism.
Kalman syndrome.
Yes, very good. This is a case of Kalman syndrome, and Kalman
Kalman
syndrome is
syndrome.
also known as the hypogonadotropic hypogonadism or hypopituitarism. and unable to smell or anosmia. This occurs.
Anosmia.
Yeah, the anosmia. The anosmia occurs due to failure to formation of the olfactory valve, and this is suggestive of the Kalman syndrome.
But not always, Dr. Ahad.
Yeah, yeah.
Yes.
In some cases of the Kalman syndrome, but if this is mentioned, it can be pointed towards the Kalman syndrome as well. Okay, let us discuss further. Okay, look at here, the Kalman syndrome. Kalman syndrome is basically the hypogonadotropic hypogonadism. So hypogonadotropic means there will be low LAs and there will be low FSAs. And the patient is usually the female, and the patient will give history of failure to initiate or failure to enter the puberty, and often the smell will be absent here. And this is an X-linked recessive condition, and there is another condition called the Klinefelter syndrome. Klinefelter syndrome is usually the in some cases this is usually the opposite of the Kalman syndrome. Kalman syndrome is the hypogonadotropic hypogonadism, but Klinefelter syndrome is the hypergonadotropic hypogonadism. So in case of Klinefelter syndrome, there will be elevated LAs and FSAs. In case of Kalman syndrome, there will be low LAs and FSAs. And the Klinefelter syndrome, this is predominantly found in the male patient. And other two conditions, Turner syndrome and androgen insensitivity syndrome. These two invariably occurs in the female patient. Kalman syndrome can be mixed. It may occur in male patient and it may occur in female patient. And look at the in case of Turner syndrome, this is XO. In case of androgen insensitivity, this is the normal XY, and in case of Klinefelter syndrome, this is hypergonadotropic, and also you will find the XXY. And Kalman syndrome will have no smell, and this comes up with the hypogonadotropic hypogonadism. And this line is very important. You will have to memorize this line till you pass your exam. If the question says normal breast with no pubic or axillary hair, or minimum pubic or axillary hair with normal breast development, and the patient is a female, the diagnosis is androgen insensitivity syndrome unless otherwise proved. So Klinefelter syndrome, this patient will come up with the features of hypergonadotropic hypogonadism with features of gynecomastia, and patient will have the Tolsteser, and the phenotype will be male patient. So sparse axillary and pubic hair with small firm testes. Since this is hypogonadism, so there will be small firm testes, but this is hypergonadotropic, so there will be elevated LAs and FSAs testes, and often the patients show the features of gynecomastia. And there is another syndrome called the Turner syndrome. This predominantly occurs in female patient, and you can remember this by using the S word. There will be short stature, there will be short neck, low set hair. Patient will have the borderline hypertension with features of primary amenorrhea, and there will be XO karyotype. And the most appropriate treatment for the Turner syndrome is the hormonal replacement therapy. So anosmia plus features of hypogonadotropic hypogonadism. This is the case of Kalman syndrome. So hypogonadotropic hypopituitarism, this is the most likely cause of a delayed puberty. Patient with AIS will come up with the normal breast development with no pubic or axillary hair. Liddle syndrome will come up with the features of hypokalemia plus hypertension. In case of primary ovarian failure, the FSH level will be elevated. And Turner syndrome, you can remember with the word S. Short stature, short wavelength. Okay, next one, please.
Also,
Yes, any question?
also in androgen insensitivity syndrome, there will be a typical history of groin swelling.
Yeah. They will have the typical history of groin swelling, but often in the question they don't mention it.
Okay.
In the question the line given is the normal breast development with absent or less pubic or axillary hair. They often skip they often skip the groin swelling or the history of herniation. Okay, next one.
Which of the following is the most appropriate way to treat his aortic stenosis? Beta blocker, biprosthetic valve, mechanical valve, nitrate therapy, transcatheter aortic valve implantation procedure. A 75-year-old man is assessed on the ward following admission with shortness of breath, progressive angina, and anemia. While he has been an inpatient, an upper GI endoscopy has identified a large gastric ulcer which was injected, and electrocardiography has identified severe aortic stenosis. 1 year earlier, he was still able to walk up to 4 miles a day with his dog. He is now unable to walk upstairs without dizziness and breathlessness. His blood pressure is 138 by 85 and his pulse is 75 and regular. He has an ejection systolic murmur. There are bilateral basal crackles on auscultation of the chest. Investigation: hemoglobin 9.7, white cell count 6.2, platelet 302, sodium 144, potassium 4.4, creatinine 145. Which of the following is the most appropriate way to treat his aortic stenosis? Beta blockade, biprosthetic valve, mechanical valve, nitrate therapy, transcatheter aortic valve implantation procedure.
So the patient is having the severe aortic stenosis and there is some source of hemolysis here. And so for the treatment of severe aortic stenosis, we have two options. We have two surgical options. One is the biprosthetic valve replacement or mechanical valve replacement. And in order to decide between the two, we know that mechanical valve replacement, in case of mechanical valve, we will have to use the anticoagulant, either the directly acting oral anticoagulant, and in some cases warfarin may be used, and there will be increased chance of bleeding. And if we look at the question, the patient has a large gastric ulcer, so we can undergo with the anticoagulation therapy, meaning the mechanical valve would be unsuitable for this patient. So we'll have to go with the biprosthetic valve because biprosthetic valve doesn't need the anticoagulation. So often the biprosthetic valve is preferred in case of aortic stenosis compared to mechanical valve. And the transcatheter aortic valve implantation procedure, this can also be used as a management of is in the management of aortic stenosis, but this gives us the temporary relief, and this is only indicated if the patient is unsuitable for the biprosthetic valve replacement. So for the severe aortic stenosis, the default choice of treatment should be the biprosthetic valve replacement. This patient has severe aortic stenosis and has been relatively well until 1 year earlier. Surgical valve repair is therefore indicated. So we'll have two options. One is the biprosthetic valve and also the mechanical valve, but the mechanical valve involves the use of anticoagulant drugs, and since the patient already has the risk of bleeding tendency, so the mechanical valve would be unsuitable in this patient. So we would go with the biprosthetic valve replacement.
And also, we prefer mechanical valves
Yeah.
in younger patients and
Yes.
biprosthetic in old patients.
Yes, exactly. The biprosthetic valve is more predominantly preferred in the older age group patient, mechanical in the younger patient, and here the patient is older patient, 75 years. Where does the aqueous humor drain? This is the direct question. anatomical question. Where does the aqueous humor drain? This is known as you know it or you don't know it type of question. So where does the aqueous humor drain?
Phlegm canal.
Yes, very
Phlegm
good.
canal.
Canal of Slem.
Canal of
The,
Skilum.
the aqueous humor drains into the canal of Slem. This is memorization question. Just memorize it. Which of the following is the number needed to treat over 4 years to save the MACE? MACE means major adverse cardiovascular event. So how to calculate the NNT, number needed to treat? What's the formula? Anyone?
1 divided by ARR.
And how to calculate the ARR?
Sir, experimental rate minus control.
Yes, very good. Okay, look at here.
Mm.
The question is about the NNT, and NNT is very important. It usually comes in every diet or every alternate diet. NNT, or number needed to treat, this is calculated with 1 divided by the absolute risk reduction. This is the, in short, ARR. And ARR is just the difference between the control event rate and the experimental event rate. In short, CER. So NNT is equal to 1 divided by ARR, and ARR is just the difference between the control and experimental. So the difference here is 9 minus 6 equal to 3. So 1 divided by 3, how much? 1 divided by 3, how much? Into
Around
100%. Since there is percentage given, we'll have to
33.
we'll have to, yeah, this is the 33. Okay, everyone clear with this math?
Yes, doctor.
Okay, so just remember NNT is equal to 1 divided by the absolute risk reduction, and ARR is just the difference. Since this is percentage, so 9 minus 3, you'll have to convert into percentage, meaning in the ratio of 100. So 1 divided by 3 into 100 is equal to 33. It's an easy solution. Okay, next one.
Should I read it?
Yeah. Though as fast as
Which
you
of
can.
the
Yeah.
following
Continue.
which of the following is the most appropriate intervention? A. Aspirin 300 mg. B. Clopidogrel 300 mg. C. Metoprolol intravenous infusion. D. Subcutaneous low molecular weight heparin. E. Alteplase. A 67-year-old man is brought to the emergency department by ambulance. He has developed sudden onset left-sided facial, left arm, and left leg weakness and decreased sensation. He has confusion and dysphagia. He has diabetes mellitus and hypertension and smokes 20 cigarettes per day. According to his wife, the weakness began some 2 hours earlier. His blood pressure is 182 by 95 and his pulse is 95 and regular. You confirm the presence of weakness consisted with an acute stroke. Investigations: HB 14, white cell count 8.1, platelets 192, sodium 144, potassium 4.1, creatinine 116. CT findings: no evidence of intracerebral hemorrhage. Which of the following is most appropriate treatment intervention? Aspirin 300 mg, clopidogrel 300 mg, metoprolol intravenous infusion, subcutaneous low molecular weight heparin, and alteplase.
So this is a case of acute ischemic stroke, and the hemorrhage has been excluded here. And we know that for the management of acute ischemic stroke, when the hemorrhage has been excluded, we'll have to look for the window period. And the window period is 4.5 hours, and this is the window period for thrombolysis. If the patient comes within 4.5 hour, we'll have to go with the thrombolysis. And the patient has come within the window period within the 2 hours, so we can go with the thrombolysis. So we go with the
Alteplase.
alteplase. Can anyone please tell me the mode of action of altiplase? Altiplase, retiplase, tenecteplase, streptokinase. What's the mode of action of this drug? Tissue plasminogen activator. Okay, they are the TPA. Altiplase, retiplase, tenecteplase, and streptokinase. All of them are the tissue plasminogen activator. And if the and if the patient came beyond the window period of thrombolysis, let's say after 4.5 hours or 6 hours, then we will go with the aspirin therapy. And the clopidogrel. Clopidogrel is not usually used in the acute management. This is reserved for the prophylaxis. Aspirin is the default choice in case of acute treatment coming up beyond the thrombolysis period, and clopidogrel, this is preserved for the secondary prevention or for the prophylaxis. And since the patient come within 4.5 year, we'll have to go with the altiplase. So 4.5 hour time window, this is for the thrombolysis in case of acute ischemic stroke. So you can go with the altiplase. Any question?
Beyond 4.5 hours, isn't it mechanical thrombectomy?
The mechanical thrombectomy, this is related to the percentage of the occlusion. If the occlusion is equal to 70% or 80%, then we can go with the thrombectomy. Okay, but the window period for thrombolysis, is the 4.5 hour.
4.5.
Yeah, if the patient come within 4.5 hour, we have to go for the thrombolysis. If the patient comes beyond this 4.5 hour, we can't undergo the thrombolysis in this patient. In that case, we'll have to go with the high dose aspirin therapy. Which of the following is most frequently seen after TIPS? Transjugular, intrahepatic, portosystemic stent procedure. And this is a direct question. No need to go for the scenario. So which of the following is most frequent? Yes, very good. The AHE, the hepatic encephalopathy. Hepatic encephalopathy is the most frequently seen after the TIPS procedure, and often we will have to give the prophylactic rifaximin in this type of patient. So AHE, the hepatic encephalopathy, this is the most common complication or most common side effects seen after the TIPS procedure. AHE is the most common complication of the TIPS procedure, and there is also some of the risk factor. Hyponatremia, sarcopenia, increasing age, prior history of hepatic encephalopathy, and if the shunt diameter is greater than 10 millimeter. Okay, next one.
Which of the following is most likely the cause of the positive wound swab? Enterococcus faecalis, Pestula multicida, Propionibacterium acnes, Staphylo aureus. A 20-year-old students come to the and Streptococcus angionosis. A 20-year-old student come to the emergency department with an infected human bite on the dorsum of his left hand, which he sustained in a play fight with his flatmate. There is erythema around the mark and it is exuding pus. A wound swab sent by his general practitioner has demonstrated gram-positive cocci. Which of the following is the most likely cause of positive wound swab? Enterococcus faecalis, Fistula multicida, Propionibacterium acnes, Staphylo aureus, Streptococcus angionosis.
Staphylococcus aureus.
Staphylococcus aureus.
The most it's
Okay.
It's animal, right?
Staphylococcus aureus.
Pasteurella is for animal bite. For human bite, it is
Staphylococcus
strap. The E option.
Yes, exactly. I'm again hearing the echo. Someone please disconnect your second device. So this patient has come up with the infected human bite. And the commonest organism found in human bite is the Streptococcus aeruginosus. And I always give the mnemonic, the angry, usually the men who are angry, they usually bite. So angry person usually bites. So Streptococcus aeruginosus, this is associated with the human bite. Pasteurella maltosida. This is the commonest organism found in dog bite. And the Cartonella or the Bartonella hanseli, this is the commonest organism in case of cat scratch disease.
Toxoplasmis.
In case of cat scratch disease, and the treatment is super important for the exam. The treatment for human bite, the first line treatment for human bite is
Co
co-amoxicillin.
co-amoxicillin.
The first line treatment for dog bite is co-amoxicillin. And for cat, remember with the C, cat scratch, C for cat. C means if compromise. So if a patient with cat scratch disease is immunocompromised, then only treatment is required. Cat scratch disease, in case of immunocompetent patient, doesn't require any treatment, and the treatment is also with the C, with the ciprofloxacin.
Fluoxetine.
So C for cat, C for immunocompromised, C for ciprofloxacin, and C for Cartonella or Bartonella hanseli. And the co-amoxicillin. Co-amoxicillin is the first line treatment in a long list of cases, and I am telling you some of them. Number one is dog bite. Number two is the infected human bite. Number three is the diabetic foot ulcer, and number four is the probably osteomyelitis. Yes, osteomyelitis. In all of the four condition, the co-amoxicillin, this is the first line of treatment. And let's discuss further regarding the dog bite management, because this is the most important. What's the commonest organism in case of dog bite? I just said a few moments ago. Pasteurella maltosida. Yes, look at here. The dog bite, the commonest organism is the Pasteurella maltosida and co-amoxicillin. Co-amoxicillin is the first line therapy both in dog bite and also in human bite. And for dog bite, you will have to remember some other cases. So we'll start with the co-amoxicillin as the first line. But if the patient is penicillin allergic, that means we can't use the co-amoxicillin. In that case, the treatment should be combination of doxycycline and metronidazole. So first line is the co-amoxicillin. If there is penicillin allergy, then the treatment should be doxycycline plus metronidazole. And if the patient is pregnant, then we can give the co-amoxicillin. But if the patient is pregnant plus penicillin allergic, because we know that in case of pregnancy, we can't use the doxycycline. So pregnant patient with history of penicillin allergy plus dog bite, the treatment should be azithromycin plus metronidazole. And for resistant cases or life-threatening condition, we'll treat with the 2C. One is the clindamycin, another one is the ciprofloxacin. So I am repeating again. First line or the default choice of treatment co-amoxicillin. This can also be used in case of pregnancy. But if there is penicillin allergic, in case of non-pregnant patient, we'll have to give doxy and metro. If the patient is pregnant, give azithro and metro. And if this is resistant case or life-threatening case, give 2C, clindamycin and ciprofloxacin. Okay, next one.
Which of the following is the most appropriate intervention? Intravenous ceftriaxone, IV flucloxacin, oral amoxicillin, oral clindamycin, oral vancomycin. A 20-year-old man comes to the emergency department with a red swollen left knee on which he is unable to weight bear and which cannot be flexed more than 30 degrees. He tells you that he fell off his bike a few days earlier and wonders if this is a cause of his knee problem. He has no medical illnesses. You confirm his left knee is hot, swollen, and tender. He has some abrasions over the anterior surfaces. Investigations: hemoglobin 14.4, white cell count 14.3, platelet 309, sodium 142, potassium 4.5, creatinine 110, C-reactive proteins 171, synovial fluid white cells greater than 50,000 per microliter. Which of the following is the most appropriate intervention? Intravenous ceftriaxone, IV flucloxacin, oral amoxicillin, oral clindamycin, oral vancomycin.
So the patient has come up with the acute monoarthritis involving the large joint here, and the patient has the left knee is red, hot, swollen, tender, and also the synovial fluid white ulcer. This is defining the infection here. So the most likely diagnosis here is the septic
Septic
arthritis.
arthritis.
And we know that the commonest organism for the septic arthritis is the Staphylococcus aureus. And Staphylococcus aureus is the gram-positive organism. So we can go with the IV flucloxacillin. This is the first line choice of treatment for septic arthritis. And IV ceftriaxone. IV ceftriaxone is more predominantly used in case of gram-negative infection, since this is the third generation cephalosporin. And just remember, regarding the cephalosporin, the first generation cephalosporin has the highest activity against the gram-positive organism, lowest activity against the gram-negative organism. As we advance towards second line, third line, and fourth line, the susceptibility or the action against the gram-positive organism will gradually decrease, and the strength against the gram-negative organism will gradually increase. So the third and fourth generation cephalosporin, they have the highest action against the gram-negative organism. The first generation cephalosporin has highest activity against the gram-positive organism, and second generation has mild action against both gram-positive and gram-negative. And IV ceftriaxone is the choice of treatment in case of uncomplicated gonococcal arthritis. And the intramuscular ceftriaxone, this is the first line choice of treatment in case of gonorrhea. So remember, in case of gonorrhea, we give the intramuscular ceftriaxone. And in case of uncomplicated gonococcal arthritis, we give the IV ceftriaxone. Oral vancomycin. Vancomycin is reserved for the methicillin-resistant Staph aureus. There is no features of MRSA here, and the most likely first line of treatment should be IV flucloxacillin here, since the Staph aureus is the commonest organism for the septic arthritis. Which of the following antibodies is most at risk of causing the neonatal heart block? So no need to read the scenario here as well. So what should be the answer here?
Anti-Ro antibody.
Yes, very good. Just remember both anti-Ro and anti-La. So both Ro and La, both of them are associated with the neonatal heart block and also with the SLE. And if the option has both anti-Ro and anti-La, you'll have to choose the anti-Ro, because anti-Ro is more predominantly found in case of neonatal heart block, less predominant with the anti-La antibody. And anti-dsDNA or double-stranded DNA, this is specific for SLE. Antihistone antibody or AHA means DIL AHA. This is associated with the drug-induced lupus. Antiphospholipid or the anticardiolipin, this is found in APAS, antiphospholipid antibody syndrome. Anti-smooth muscle or asthma, this occurs in AIH, autoimmune hepatitis. So anti-Ro and anti-La, this is associated with the neonatal heart block. Okay, just tell me one thing. Anti-Ro and anti-La, are they IgG or IgM? They are causing the neonatal heart block. So are they IgG or IgM? Yes, very good.
IgG.
Because we know that only the among the immunoglobulin, only the IgG, they can cross the placenta, and the neonatal heart block can only be caused if this component has crossed the placenta. So the IgG, they will cross the placenta. For this reason, anti-Ro and anti-La, they are the IgG, they are crossing the placenta, and they are causing the neonatal heart block.
Doctor,
Yes, please.
they are both IgA, IgM, and IgG, but the more amount of IgG is present.
Yes, exactly. The
So?
more amount of IgG is there predominantly. They are actually the predominantly IgG antibody. The IgM and IgA are so negligible that we no need to consider them. Okay, we can just consider they contain the IgG in terms of predominance. Okay, next. Sorry.
At 39, which of the following is most appropriate intervention over the first few months? Carbimazole, carbimazole and thyroxine, prothiouracil, radioiodine, thyroidectomy. A 39-year-old woman comes to the endocrine clinic with weight loss, palpitation, anxiety, and a persistent tremor which has worsened over the past few months. Her blood pressure is 110/70 and her pulse is 95 and regular. She has a fine tremor at rest and sweaty palms. Her body mass index is 20 and she has a smooth goiter which is mildly tender on palpation. She has bilateral exophthalmos. Investigations: hemoglobin 12.9, white cell count 6.2, platelet 238, sodium 140, potassium 4.7, creatinine 98, TSH less than 0.05. Which of the following is most appropriate intervention over the first few months? Carbimazole, carbimazole and thyroxine, propylthiouracil, radioiodine, thyroidectomy.
So this patient has the features of thyrotoxicosis as well as the exophthalmos or the thyroid eye disease. So what should be the most appropriate intervention over the first few weeks? We should
Block
go
and
with the
replace.
yes, very
Carbimazole
good.
and thyroxine.
We'll have to for the first few months in case of thyroid eye disease, we'll have to go with the block and replace regimen by giving the high dose of thyroxine and also the carbimazole and the radioiodine. We know that the radioiodine this causes worsening of the thyroid eye disease. So the block and replace regimen with combination of carbimazole and thyroxine should be the most appropriate over the first few months. Combination therapy with high dose carbimazole and thyroxine replacement. This is known as the block and replace regimen. Okay, next one.
Which of the following is the most appropriate next step? A 24-hour ambulatory blood pressure monitoring. B, 24-hour ECG recorder. C, CT head. D, EEG. Reassurance and discharge. A 24-year-old woman is brought to the emergency department having suffered transient loss of consciousness while at work. She reports that after standing for a long period in one place listening to a talk, she began to feel very lightheaded, and then the world began to close in and the room went dark. Next thing she remembers is waking up on the floor with colleagues standing around her. She has no significant medical illnesses. According to colleagues, she was unconscious for approximately 30 seconds. Her blood pressure is 118/70 and her pulse is 65 and regular. Body mass index is 23. The EEG shows normal sinus rhythm with QT interval of 390 seconds. Which of the following is most appropriate next step? 24-hour ambulatory blood pressure monitoring, 12-hour ECG recorder, CT head, EEG, and reassurance and discharge.
So what's the diagnosis here? The scenario? Can anyone tell me the diagnosis here? Everything else is normal, just the transient loss of consciousness. So what's the diagnosis?
Vasovagal.
Yes, this is a case of
Syncope,
vasovagal syncope. And what should be the most appropriate step for vasovagal syncope?
reassurance and discharge.
Yes, very good. Reassurance and discharge. Just look at here, the patient just has the transient loss of consciousness. Everything else is normal. So this is a case of vasovagal syncope. So we can just reassure the patient. Okay, next one.
Which of the following is most appropriate intervention? Cinacalcet, furosemide, prednisolone, reassurance, referral for parathyroidectomy. A 72-year-old woman presents to her general practitioner for review, complaining of constipation and aching bones, and she is up passing urine on 2 to 3 occasions per night. She has hypertension, which is treated with Remepryl and indapamide, but she is otherwise well. Her blood pressure is 142/90, and her pulse is 72 and regular. Her body mass index is 28. Investigation: hemoglobin 11.9, white cell count 6.2, platelets 259, sodium 144, potassium 4.7, creatinine 122, corrected calcium 2.95, phosphate 0.65 micromole per liter, parathyroid hormone 6.7. Which of the following appropriate intervention? Cinacalcet, furosemide, prednisolone, reassurance, refer for parathyroidectomy.
So there is hypercalcemia, low phosphate level, and the parathyroid hormone level is near the upper limit of normal range. So looking at this picture, what should be the most likely diagnosis here?
It's primary
Primary.
Yes, very good. This is the case of primary hyperparathyroidism, and primary hyperparathyroidism is often treated using the surgical option like parathyroidectomy. And to go for surgical option or parathyroidectomy, in case of primary hyperparathyroidism, we'll have two criteria. Number one is either the clinical criteria, number two is the laboratory parameters. So if the laboratory parameters, if the lab value shows the serum calcium level is greater than 2.85 or above. So this is satisfying the laboratory parameters here. And among the clinical criteria, if the patient has the symptomatic hypercalcemia. So what are the condition that indicates the symptomatic hypercalcemia? Number one is there will be either frequent,
Constipation.
there will be either frequent or excessive urination. Patient might have excessive thirst. There may be constipation, and there may be end organ damage. And end organ damage or end organ disease will point towards either it may be due to renal stone, or there may be fragility fracture here and the osteoporosis here. So constipation is one of the clinical criteria for symptomatic hypercalcemia. And aching bone pain may be explained by either renal stone or due to fracture or osteoporosis, which will indicate the end organ damage. And the patient calcium level is greater than 2.85. So all of them are satisfying the criteria for the surgical option. So we'll have to go with the referral for parathyroidectomy. So remember, one is the laboratory parameters. The calcium level should be greater or equal to 2.85. And there are clinical parameters. Clinical parameters are the symptoms of hypercalcemia. There may be thirst. Okay, let me show. So the clinical parameters should be either thirst, frequent or excessive urination, or constipation, or end organ damage like renal stone, fragility fracture, or osteoporosis. And the albumin adjusted serum calcium level should be 2.85 millimole per liter or above. In that case, it was greater than 2.85. The patient has the features of constipation, and also there is bone pain, and bone pain can be explained by either renal stone or fragility fracture or osteoporosis. So the surgical intervention therapy is being satisfied here, so we can go with the parathyroidectomy. Okay, next one.
Which of the following is most important marker for his UC severity? Blood in stool, WCC 11.1, potassium 3.4, stool frequency, temperature 37.6 degrees Celsius. A 29-year-old man is referred by his general practitioner to the rapid access colitis clinic. He has been diagnosed 4 years ago with ulcerative colitis. His symptoms have previously been well controlled with methacillin tablets. He is routinely urinating 4 times per day and has diarrhea mixed with mucus and nausea. His temperature is 90 degrees Celsius and his pulse is 69 beats. There is minimal left-sided tenderness on palpation. Investigations: hemoglobin 13.5, WBC count 11.1, platelets 395, sodium 143, potassium 3.4, creatinine 95, erythrocyte sedimentation rate 8 mm per hour. Which of the following is most important marker for his ulcerative colitis severity? Blood in stool, WCC 11.1, potassium 3.4, stool frequency, temperature 37.6 degrees Celsius.
So this is a case of ulcerative colitis, and they are asking about the assessment or marker of the ulcerative colitis severity. And there are a long list of parameters, and among the parameters, two are more commonly used. One is the true love and Wits criteria, and another one is the Montreal criteria or classification. And in both of them, the still frequency. The still frequency is the most important marker of ulcerative colitis severity. And for the stool frequency, we'll have to remember the range 4 to 6. If the stool frequency is if the range is between 4 to 6 per 24 hour, this indicates moderate ulcerative colitis. If the frequency is greater than 6, this indicates severe ulcerative colitis. If the frequency is less than 4, this indicates mild ulcerative colitis. So just remember the range 4 to 6. 4 to 6 indicates moderate, greater than 6 severe, less than 4 is the mild. So one is the Montreal classification and another one is the True Love and Wits criteria. And True Love and Wits criteria is more commonly used, and both of them has the stool frequency and the range. It ranges between 4 to 6, greater than 6 severe, less than 4 mild cases. Okay, next
Which
one.
of the following is the most appropriate treatment? A. Azithromycin. B. Ciprofloxacin. C. Coimoxiclav. D. Cotrimoxazole. E. Metronidazole. A 24-year-old climber is admitted on the acute medical take with a sudden onset of flu-like symptoms and a profuse watery diarrhea. He has just returned from an expedition to Nepal. His temperature is 37.9 degrees Celsius, blood pressure 100/60, with a pulse of 95. He is unable to stand due to dizziness. His abdomen is generally tender with a mild distension and active bowel sounds. You start him on intravenous IV fluids. Investigations: hemoglobin 13.9, white cell count 11.8, platelets 302, sodium 143, potassium 3.1, creatinine 142, stool positive for Slycospora. Which of the following is most appropriate treatment? Azithromycin, ciprofloxacin, coimoxiclav, cotrimoxazole, metronidazole.
So this is a case of cyclospora infection, and C for cyclospora, and treatment can also be remembered by using the C. C for cotrimoxazole, C for ciprofloxacin, and always remember for the treatment of cyclospora, cotrimoxazole is the first line treatment, and ciprofloxacin is usually used in the reserved cases. So cyclospora infection, go for cotrimoxazole. You need to memorize this. For cyclospora infection, cotrimoxazole is the first line. Second line is the ciprofloxacin.
Which of the following is the most appropriate choice for fluid management? 0.45% saline, 0.9% saline, compound sodium lactate, 5% dextrose, 5% dextrose, and 40 mg intravenous furosemide. A 75-year-old man is brought by ambulance to the emergency department, having been found collapsed on the floor when his home help visited. It is unclear how long he has been on the floor for. He has hypertension, ischemic heart disease, and type 2 diabetes. He is unconscious and his temperature is 38.2 degrees Celsius, blood pressure 95/60, and pulse is 95 and regular. He has crackles at the right base on auscultation of the chest. Tone is increased on right-sided and hand side. Investigation: hemoglobin 12.4, white cell count 16.1, platelets 323, sodium 161, potassium 5.4, creatinine 179, bicarb 19, glucose 23. Which of the following is the most appropriate choice for fluid replacement? 0.5% saline, 0.9% saline, compound sodium lactate, 5% dextrose, 5% dextrose, and 40 mg IV furosemide.
So the patient is having the features of hypotension with tachycardia, and if we look at the cell count, the WBC is elevated, hemoglobin is normal, and also there is hypernatremia, there is hyperkalemia, there is elevated creatinine, there is low bicarbonate level indicating metabolic acidosis, and glucose level is elevated here. So most likely the patient has the hypovolemic hypernatremia here. So for the management of hypovolemic hypernatremia, what should be the most appropriate choice of fluid management?
0.9% saline.
Yes.
Does it look like
Yeah.
shock? It looks like a septic shock, doctor. Because
No.
other than hypovolemic hypernatremia, there is white cell count also raised with all the signs of the shock.
Yes, exactly. This can be explained by the septic shock as well, because in case of septic shock, there will be hypotension.
Temperature is normal, no?
But
The
temperature, oh no,
temperature is not.
the temperature
Okay.
is the temperature.
But it's also high.
Temperature is high.
No, 38,
Thirty-
38.2 is high.
Yeah,
38.2
it's
is high.
shock. It's sepsis.
So the most likely diagnosis, there has been the ongoing sepsis here, or some sort of septic shock here, and also the patient has symptoms of hypovolemia here with the hypernatremia. It is crucial to treat the hypernatremia, so we'll have to go with the 0.9% saline. Okay, let's see the diagnosis here. What diagnosis is given? Saline 0.9% or normal saline is recommended for the management of patients who are likely hypovolemic. Okay, they haven't mentioned regarding the diagnosis here, but the most likely that this is a case of shock. This is a case of ongoing sepsis. And irrespective of the diagnosis, the patient should be treated with the IV normal saline. In this case of scenario, with the features of hypovolemia plus hypernatremia. Okay, next one.
Which is the most likely cause of the changes affecting her fingers? Hyperparathyroidism, osteoarthritis, pseudo-hypoparathyroidism, psoriatic arthritis, rheumatoid arthritis. A 65-year-old retired mechanist come to the rheumatology clinic for review. Her main complaint is of pain and stiffness affecting the distal interpharyngeal DIP joints. On examination, you note marked bony swelling and stiffness over the distal interpharyngeal joints. There are no signs of nail pitting, which is the most likely cause of the changes affecting her fingers. Hyperparathyroidism, osteoarthritis, pseudo-hypoparathyroidism, psoriatic arthritis, rheumatoid arthritis.
So the DIP joint is involved here, and always remember, if the DIP joint is involved, then the rheumatoid arthritis is
Rheumatoid
excluded.
arthritis.
No. If the DIP joint is involved, the rheumatoid arthritis is excluded, because rheumatoid arthritis, the rheumatoid arthritis will affect the PIP and the MCP joint, proximal
PIP.
interphalangeal joint and metacarpophalangeal joint, and there will be symmetrical joint involvement. There will be symmetrical polyarthritis. So rheumatoid arthritis, this will involve the PIP and MCP. Rheumatoid arthritis spares the DIP joint. So if DIP joint is involved, number one, the rheumatoid arthritis is excluded. Now, the DIP joint involvement is predominantly associated with three conditions. Number one is osteoarthritis. Number two is psoriatic arthritis. Number three is the adult onset steel disease. So how do we differentiate between osteoarthritis and psoriatic arthritis? Osteoarthritis is a degenerative disease. This will occur in the older age group patient, and the patient will have no features of morning stiffness. There will be no features of skin involvement. There will be no dactylitis. In case of psoriatic arthritis, the patient will have the features of skin involvement. Either there will be nail pitting or some sort of dermatological involvement, or there might be dactylitis. Dactylitis means inflammation or swelling of the entire length of a finger. So if a patient comes with DIP joint involvement plus features of degeneration with no features of nail pitting and also no dactylitis, the most likely diagnosis is the osteoarthritis. And DIP joint involvement plus either nail pitting or skin involvement or dactylitis, the diagnosis should be the psoriatic arthritis. And adult onset steel disease, this is the diagnosis of exclusion. This occurs with the negative rheumatoid factor. So if we look at here, the patient is old here and the patient is a retired machinist, and retired machinist means he had exposed for a longer period of time related to his occupation, and this has caused her inflammation, pain and stiffness around the DIP joint. So the most likely here should be the osteoarthritis. And I am repeating again, if DIP joint is involved, rheumatoid arthritis is excluded. After that, then look whether nail pitting, skin involvement, or dactylitis, or any features of morning stiffness is present. If any of them is present, and especially the patient is young patient, then the most likely diagnosis is the psoriatic arthritis. If there is no nail pitting, no skin involvement, then no dactylitis. There is no features of morning stiffness. The patient is old and there is features of degeneration of repetitive work related to the occupation. The most likely diagnosis is the osteoarthritis. So how will you treat a case of osteoarthritis of the hand?
Topical NSAIDs
Yes, very good.
for
Oral paracetamol, followed by topical NSAIDs for osteoarthritis of the hand and osteoarthritis of the knee joint. Okay, next
and
one.
so we can even remember the lesion described post bony swelling of DIP, which is Herberden's
Oh,
nodule.
yes,
So,
exactly. Oh, okay.
so the mnemonic is high burden, Herberden dip, high burden dip. Burden is osteoarthritis and in the DIP joints.
Yes, exactly.
Just to remember it.
Osteoarthritis, this is associated with the Heberden's node, and Heberden's node means node in the DIP joint, and the Boucher node, this is associated with the rheumatoid arthritis. So the node involving the DIP joint, this is known as the Haverden's node, and the Haverden's node indicates the osteoarthritis. But if the entire length of the finger is inflamed or swell, this indicates the dactylitis. This will point towards the psoriatic arthritis. Okay, thank you, doctor, for reminding me. Okay, next one.
Which of the following is the most appropriate intervention? Intraperitoneal vancomycin, oral ciprofloxacin, and intraperitoneal vancomycin, oral ciprofloxacin and oral vancomycin, oral ciprofloxacin and intraperitoneal gentamicin, oral ciprofloxacin and intravenous gentamicin. A 67-year-old man who uses intermittent peritoneal dialysis to manage his end-stage renal failure comes to emergency department. He has been unable to completely drain out his overnight bag and it is cloudy. He also has abdominal pain. His temperature is 38.2 degrees Celsius, blood pressure 115 by 83, and pulse is 92 and regular. His abdomen is mildly distended with active vowel sounds. It's generally tender. Investigations: HB 9.3, white cell count 16.2, platelet 301, sodium 144, potassium 4.8, creatinine 542, C-reactive protein 225, peritoneal fluid microscopy 250 white cells per ml, no organism. Which of the following is the most appropriate intervention? Intraperitoneal vancomycin, oral ciprofloxacin, and intraperitoneal vancomycin, oral ciprofloxacin and oral vancomycin, oral ciprofloxacin and intraperitoneal gentamicin, oral ciprofloxacin and intravenous gentamicin.
So what's the diagnosis here?
SPP.
CAPD peritonitis.
Yes, exactly. This is the case of peritoneal
I can't
dialysis
hear, doctor.
related PD related peritonitis, and the commonest organism for PD related peritonitis is usually the staph epidermidis, and the default choice of treatment are the ciprofloxacin and vancomycin. And vancomycin should always be given intraperitoneally in case of PD related in case of peritoneal dialysis related peritonitis. And ciprofloxacin can either you can give orally or in the interperitoneal form. And always remember, the vancomycin should be given in oral form in case of Clostridium difficile infection. So intraperitoneal vancomycin is given in case of PD-related peritonitis, and oral vancomycin plus minus IV metronidazole, this is given in case of Clostridium difficile infection. So PD-related peritonitis is treated with oral ciprofloxacin and intraperitoneal vancomycin. This is the choice of treatment. Okay, next one.
Which of the following is the optimal way to reduce her risk of osteoporosis? Calcium and vitamin D, hormone replacement therapy, oral contraceptive pills, raloxifene, risedronate. An 18-year-old woman who has Turner syndrome comes to the clinic for review with her mother. She is concerned about long-term complications of the disease, including osteoporosis. Which of the following is the optimal way to reduce her risk of osteoporosis? Calcium and vitamin D, hormone replacement therapy, oral contraceptive pill, raloxifene, risedronate.
So patient with Turner syndrome to reduce the risk of osteoporosis. Yes, exactly.
Hormone replacement therapy?
Yes, we just discussed. I just show you a little more. Check. So just look at here, Turner syndrome, hormonal replacement therapy. This is the most appropriate treatment for the management of osteoporosis in a patient with Turner syndrome, because this comes up with the hormonal defect. So we'll have to replace the hormone. Can anyone please tell me the mode of action of raloxifene?
SCRM.
Yes, very good. Raloxifene and tamoxifen. Tamoxifen and raloxifene, they are the SERM, selective estrogen receptor modulator, and they are used in the treatment for postmenopausal osteoporosis. What's the indication of risedronate? Everyone knows, all right? Risedronate is the first line treatment for which one? Postmenopausal osteoporosis, and they are the oral bisphosphonate. Which of the following is the most important adverse effect of trastuzumab therapy? Okay, first tell me the mode of action of trastuzumab. Which receptor is it blocking?
HER2.
Yes, very good. The trastuzumab is the HER2 receptor antagonist. This will block the HER2 receptor, and the HER2 receptor itself, this is beneficial. This is beneficial for the cardiac muscle. This gives protection against the cardiomyopathy. So if you are blocking the HER2 receptor by giving the trastuzumab, the cardioprotective effects against the cardiomyopathy will be gone. So the patient will come up with the features of dilated cardiomyopathy, and dilated cardiomyopathy will ultimately give rise to cardiomyopathy followed by the heart failure. So trastuzumab therapy, this is associated with the DCM. DCM will lead to cardiomyopathy, and always remember trastuzumab is the HER2 receptor antagonist. Which one causes the hemorrhagic cystitis?
Cyclophosphamide.
Yes, very
All
good.
the calcineurin inhibitors.
Yes.
Cyclophosphamide, cyclosporin as well.
So hemorrhagic cystitis is most commonly seen in case of cyclophosphamide, and to counter this effect, we'll have to add the mesna along with the
Mesna.
yes, mesna along with the cyclophosphamide. And pneumonitis, there is a long list of condition which causes the pneumonitis, and you will have to memorize
Methotrexate.
yes, and you will have to memorize the agents or the components causing predominantly upper zone fibrosis and predominantly lower zone fibrosis. And always remember the drugs, all the drugs, the methotrexate, the amiodarone, the bleomycin, all of them usually affects the lower zone of the lung. They predominantly causes the lower zone fibrosis, all the drugs.
Which of the following is the most appropriate next intervention for his cardiac failure? A. Doxazosin, B. Ivabradine, C. Sacubitril, valsartan, D. spironolactone, E. hydroxyline. A 65-year-old man comes to the cardiology clinic for review. He has symptoms of shortness of breath and only able to climb the stairs once per day. This is treatment with ramipril, bisoprolol, and minimizes the cardiac area. His blood pressure is 122 by 84, and his pulse is 64 and regular. He has no ankle swelling and only sparse freckles at the base, both bases on auscultation of the chest. His ejection fraction was measured at 29% some 6 months earlier. Investigation: hemoglobin 13.5, white cell count 8.1, platelet 281, sodium 139, potassium 4.4, creatinine 132. On X-rays, cardiomegaly, no evidence of left ventricular failure. Which of the following is the most appropriate next intervention for his cardiac failure? Doxazosin, ivabradine, sacubitril, valsartan, spironolactone, hydralazine.
So this is a case of congestive cardiac failure, and this is also low ejection failure. This is a case of low ejection systolic failure. The heart low ejection fraction induced heart failure, and the patient is already getting the AC inhibitor, beta blocker, and the loop diuretics, and they are asking about the fourth line of drug. So what should be the most appropriate intervention here?
The potassium sparing.
Spironolactone.
Potassium sparing.
Can anyone tell me the precondition for using the ivabradine? Two conditions.
More than 75 heart rate, less than 30% ejection fraction, or 35%.
35.
Yes, 35. Okay.
30.
Less than 35%. 1 minute. Ivabradine. Someone's microphone is creating trouble. Please unmute yourself. Okay, chronic heart failure drug management. The first line treatment should be give both AC inhibitor and beta blocker. And in this scenario, the patient was giving both AC inhibitor, beta blocker plus the loop diuretics. And the second line treatment or the third line treatment is usually the spironolactone or the epinephrine. Spironolactone, this is associated with the painful gynecomastia. So if a patient after giving spironolactone develop the gynecomastia, we'll have to switch from spironolactone to epinephrine. And for the third line treatment, we'll have to go for the specialist review, and there is a long list of options here. Ivabradine, sacubitril, valsartan, hydrazine in combination with nitrate, digoxin, and cardiac resynchronization therapy. And each of them has the special criteria. And the criteria for ivabradine is very important for your exam. The heart rate should be greater than 75%. Probably in past medicine, it is written the heart rate is greater or equal to 75%, 75 beat per minute, but this is wrong. The heart rate should be greater than 75, not equal to 75. If the heart rate is equal to 75 beat per minute, you can't use the ivabradine. The ejection fraction should be less than 35. Heart rate should be greater than 75. These two are the strict criteria for using the ivabradine. And for sacubitril valsartan, the ejection fraction should be less than 35 and is considered in the heart failure with reduced ejection fraction who are symptomatic of AC inhibitor or ARBs, and they should be given following the AC inhibitor or ARB washout period, meaning give the AC inhibitor and the ARBs for a longer duration of time, still the patient symptomatic, not fulfilling the criteria for ivabradine, go for sacubitril valsartan. Digoxin is only used if there is coexistent atrial fibrillation, and hydralazine in combination with nitrate, this is only limited to the Afro-Caribbean patient. And if there is features of any type of heart block, this is either evidenced by the left bundle branch block or wide and QRS interval, then you have to choose for the cardiac resynchronization therapy. So for heart block or wide and QRS, go for cardiac synchronization. Sinus, the heart rate greater than 70 and ejection fraction less than 35. Then this was strict criteria for the ivabradine. So heart rate.
What about SGL2 inhibitor in case of management of chronic heart failure?
HCl inhibitor is the, I am hearing the echo again. HCl-T2 inhibitor is the anti-diabetic drug. This will only be used if the patient has some sort of heart failure or some sort of renal impairment, because the HCl-T2 inhibitor drugs, they have the cardioprotective action and the renoprotective action. So if a patient with diabetes has either heart failure or renal impairment, then you will have to give the HCl-T2 inhibitor. This is for the management of diabetes, not for the management of heart failure itself.
No, no, Dr. Ahad, I think past medicine has mentioned this SGLT2 inhibitors. Mm, as I think in third, that one para is there in third line or fourth line.
Yes, in the second line
Yeah,
therapy.
yes. So can you please mute your mics?
Is in the cardiology or in any other system?
No, cardiology. They have
In
mentioned it
cardiology, yeah.
specifically.
Name of the topics?
Yeah, Dr.
Name of the topics?
Name of the topic is
Heart
cardiac
failure
failure.
management.
Yeah, yes.
So here we are talking about low ejection fraction, in which SGL2 inhibitors are. I can hear my echo.
Okay, carry on, please.
Yes. So here we were talking about low ejection fraction, less than 35%, that SGL2 inhibitors are not recommended in low ejection fraction. What I remember
No, doctor.
from what I've read.
The doctor who was asking this, he was just mentioning what is the role, because the Europeans have recently found out.
Yeah, it has cardioprotective action.
Absolutely.
Yeah, it has. Dr. R, can you please mute your mic? Yes, it has cardioprotective action, but then that is not recommended in low ejection fraction. The guidelines for heart failure, what Dr. Hart told, they are the ones which we need to know when we deal with low ejection fraction.
Yes, doctor. The doctor was just trying to understand the role of SGLT2
Okay.
inhibition.
Okay.
Yeah.
Okay, so I will look further into the matters and let you know after tomorrow. Okay, so we can continue with the next question. Okay, carry on, please.
Which of the following is the most likely cause of this patient's raised total T4? Graves' thyroiditis, Hashimoto's thyroiditis, hyperemesis gravidarum, normal pregnancy, thyroiditis of pregnancy. A 29-year-old woman is referred to the endocrine clinic for review. She is 16 weeks pregnant and is increasingly tired. Her general practitioner is concerned that she may have a problem with her thyroid gland. Her blood pressure is 100/70 and pulse is 75 and regular. Her body mass index is 22. Investigation: hemoglobin 3, 104, potassium 4.5, creatinine 98, TSH 5, total T4 192. Free T4 21. Which of the following is most likely the cause of this patient's raised T4? Graves' thyroiditis, Hashimoto's thyroiditis, hyperemesis gravidum, normal pregnancy, thyroiditis of pregnancy.
So if we look at the pictures here, the free T4 level is normal here, only the total T4 level is elevated here, and TSH level is within the lower limit of normal range. So elevated total T4 level with normal FT3 and FT4 was the most likely underlying cause. This occurs in case of pregnancy, right?
Yes, sir.
Thyroglobulin
Tyrosine
levels.
binding globule.
Normal physiology of pregnancy.
Yes.
Okay, look at here. Raised total T3 and T4, but normal free T3 and free T4 shows high concentration of the thyroid binding globulin, and this thyroid binding globulin, this is elevated in case of pregnancy, and this elevated thyroid binding globulin, this will give rise to the raised total T3 and T4, but the free level of the hormone will level normal. And in case of Graves' thyroiditis, there will be features of hyperthyroidism. In case of Hashimoto thyroiditis, there will be features of hypothyroidism. In case of hyperemesis gravidarum, the patient will have significant history of the vomiting, and the patient will have the low TSH level. But the TSH level is within the normal limit here. Thyroiditis of the pregnancy. Thyroiditis of the pregnancy usually occurs in the postpartum or the peripartum course, and this will have some sort of painful goiter, and the picture will be somewhat else. So with the elevated total T4 and T3 with the normal free hormone level, the most likely diagnosis is due to the normal pregnancy due to the increased circulating thyroid binding globulin. Which of the following antibodies is the cause of a hyperthyroidism? And the patient has the exophthalmos consistent with the Graves' ophthalmopathy. So we just discussed. This is almost a type of
Anti-MPO.
why anti-MPO?
Thyroid stimulating. No, thyroid stimulating. It is Graves' ophthalmopathy.
NT-TSH.
TSH, yeah.
Yes.
NT-TSH.
The long-acting anti-TSH receptor antibody. This is associated with the Graves' ophthalmopathy, and anti-MPO is positive. Can you hear me? Hello, can you hear me clearly?
Yes.
Okay.
Yes, sir.
Anti-MPO antibody, this will be found in case of microscopic polyangiitis and also in case of Charles-Ross syndrome, not in case of Graves' ophthalmopathy. And anti-TPO is found also in Graves of anti-TPO antibody is found in case of Graves' disease and also in case of Hashimoto thyroiditis. Anti-TTZ in case of celiac disease. Okay, just give me 1 minute, please.